Yesterday we have discussed about the liver markers. Okay, what are the markers for the liver injury and what are the markers for the liver function? Okay, like we've discussed about the ALT, ASTs, alkaline phosphate, the GGT, right? We have discussed how these markers, if rise, that means a liver injury, right? In case of the bilirubin, albumin, the prothrombin time, and the platelet count, right? It shows that the liver is being, it shows the liver dysfunction, right? How much damage to the liver has been occurring. By checking the levels of these markers, you can easily know, right? We have discussed about the Reis syndrome, how it can inhibit the beta oxidation, and as a result, the fatty liver will occur, right? And the patient will also get the hepatic encephalopathy. We have discussed about the alcoholic liver diseases, right? There is stages like the first stage got the hepatic steatosis, then the alcoholic hepatitis, and then the alcoholic cirrhosis. We have discussed what markers rise in these conditions. Okay, we have discussed about this ALT and AST. That AST is always higher than the ALT in case of alcoholic liver diseases, right? And both this ALT and AST, they must be less than 500 international units. Okay, and we have discussed about the histology of these hepatocytes in case of all three stages, right? We have discussed about the non-alcoholic fatty liver disease, that it will show in the metabolic syndromes in which the patient has a very high lipid count, obesity, diabetes, hypertension, atherosclerosis could be there, right? And low STL and high LDL levels. And in that case, the patient can also have the non-alcoholic fatty liver diseases. We have discussed about the hepatic encephalopathy, what happens when the liver dysfunction occur, right? The hyperammonia thing, and what triggers the hyperammonia, right? That is the increase in the production and decrease in the clearance, right? Then we have discussed about the autoimmune hepatitis and the patterns of liver injury, that in case of any liver injury, you will have the high ALT, AST, than the alkaline phosphate. In case of a cholestatic pattern of liver injury, you will have the high level of alkaline phosphate than the ALT and AST. We have discussed about the causes of the hepatocellular carcinomas, right? Any cause of cirrhosis, any cause of hepatitis, or any congenital disease of the liver, they can cause the hepatocellular carcinomas. Other important causes, dietary ones, they include the the aflatoxins from the aspergillus, right? We have discussed what findings you will get. With the obstructive jaundice can happen sometimes, right? And the jaundice, then the tender liver would be there, hepatomegaly would be there, fever, weight loss, anorexia would be there, right? On the CT scan, you will show an enlarged mass, okay? A solo lesion would be there along with some multiple smaller lesions, right? In case of metastasis, you will get the multiple lesions of same size, right? We have discussed other liver cancers like the angiosarcoma, okay? What are the causes of angiosarcoma? This would be the arsenic and the polyvinyl chloride, and you will get the PK molecules, the cavernous hemangioma, which is the most common type of cancer, right? And it is benign and the biopsy is contraindicated. What you will see is a dilated blood vessels without any stroma. Then the hepatic adenoma, which is seen only in the patients taking the OCPs, right? And then the metastasis. And the most common route of the metastasis to the liver is the portal vein, because most of the cancers from the GIT, especially the colon cancer, they will metastasize to the liver, and they can be shown as the multiple nodules or multiple lesions of same size, right? We've discussed about the Budd-Chiari syndrome. We have discussed about the alpha-1 antitrypsin deficiency, in which you have a positive globules within the hepatocytes, within the endoplasmic reticulum of the hepatocytes. Okay, so they are kind of indegradable, right? And they will start accumulating. They will cause a cirrhosis. They will cause the pan-acinar emphysema. We have discussed about the focal nodular hyperplasia, that the cause of this FNH is basically the hyperperfusion. In response to the hyperperfusion, the cells will start proliferating and they will form this mass. It is a complete benign structure, right? It has some, on the center, it has a stellate scar. And from the scar, there will be fibrous septas, which will be dividing this complete nodule or this thing into a multiple nodules, right? Yeah, so that was everything we studied yesterday, and today we're going to start with the jaundice. Okay. So jaundice is basically a yellowish discoloration of the skin and the mucosal surfaces, right? And it is because of the high deposition of the bilirubin, right? The bilirubin is responsible for the yellowish discoloration of your body, your stool, your urine, right? So hyperbilirubinemia, it can be of two things. It can be because of two things. One is the increased production, and second is the decreased clearance. If you have a high production, you can have a hyperbilirubinemia. If you have a low clearance, then also you can have a hyperbilirubinemia, right? High production can be due to the hemolysis. If the hemolysis is more, then more heme will be converted into the bilirubin, right? In case of decreased clearance, it could be because of the impaired hepatic uptake. It could be because of the conjugation defect. It could be because of the excretion defect, right? So let's discuss all these causes one by one, okay? And just give me a second. Okay, the first one is the conjugated and or also known as the direct hyperbilirubinemia. Okay, please note that the conjugated bilirubin can also be known as the direct bilirubin. Okay, and unconjugated bilirubin is known as the indirect bilirubin. Okay, so step one can either give you this conjugated and unconjugated name, or they can also give you the direct and the indirect name, right? So do not get confused. Okay. So what are the causes of conjugated hyperbilirubinemia? See, conjugation is happening, which means the liver is absolutely normal. Okay. And because the conjugated hyperbilirubinemia is there, that means the defect must be lie after the liver, right? It could be because of the obstruction. Okay. And the causes of obstruction includes the gallstones, the cholangiocarcinoma, okay, the pancreatic cancer. Remember, if you have the cancer of the head of the pancreas, then it can block the ampulla of Vater, right? And if the ampulla of Vater is being blocked, then you will have the conjugated hyperbilirubinemia, right? Liver fluke can also do that, right? Second one includes the biliary tract diseases. In case of biliary tract disease, you will have an absolutely normal liver, right? But the biliary tracts are being damaged, and as a result, all of the bilirubin will be leaked out of the liver and will be entering into the blood circulation, right? So the causes includes the primary sclerosing cholangitis, and the second includes the primary biliary cholangitis. Okay, so primary sclerosing cholangitis, and second is a primary biliary cholangitis. Third one is the excretion defect, in which you have a congenital, uh, you know, defect in the excretion of the bilirubin. Okay, and these includes the Dubin-Johnson syndrome and the Rotor syndrome. Okay, Dubin-Johnson syndrome and the Rotor syndrome. So remember these causes for the conjugated or the direct hyperbilirubinemia. Okay, the pathology must be lie after the conjugation of the bilirubin in the liver. It could be a obstruction defect. It could be a damage to the bile tract. It could be a could be a hereditary excretion defect, right? In these cases, you will have a high level of conjugated bilirubin. You will high level of bile salts. You will also have the high level of cholesterol. In any of these conditions, you can have a high level of cholesterol, and that can lead to the xanthoma also. If you guys remember from the CVS lecture, we have discussed about all the causes of xanthomas and thalasmas and the corneal arcus, right? And the Achilles tendon xanthomas, remember?
Yes.
Yes. So we can have the xanthomas because of high cholesterol level in case of any obstruction, right? Now, the second one is the unconjugated, also known as the indirect hyperbilirubinemia. In, in this case, okay, the defect lies in the conjugation of the bilirubin, right? The indirect bilirubin is there, but it cannot be converted into the direct one, right? And the causes includes either could be due to a increased bilirubin production, which could be due to the hemolysis, right? It could be due to the physiologic causes, which is generally seen in the newborn, because in newborn you will have a low level of this UTP glucuronidase enzyme. As a result, the speed of the conjugation is very much low in case of newborns, so they can have a hyperbilirubinemia. Third thing is the defect in the a proper defect in the conjugation, which is the Kliger-Naja syndrome and the Gilbert syndrome. Okay, remember these two defects in which you have a complete defect in the conjugation. In case of hemolysis, you will be having a high production of the bilirubin. In case of physiologic, it is because of a low speed or low affinity of the enzyme, right? Third thing is the mixed type, in which you have this, both the indirect as well as the direct hyperbilirubin levels high, right? And the causes includes a direct liver injury. Whenever you have a liver injury directly, you can have a high level of both direct as well as the indirect bilirubin, right? And the causes includes the hepatitis and the cirrhosis. Okay, very important. Yeah, that would be everything. Any doubts so far?
No, thank you.
Then comes a scenario which is known as the physiological neonatal jaundice. Okay, very important. It is basically just defect which were discussed about the unconjugated or the indirect hyperbilirubinemia. We've discussed a physiologic cause, right? It is a physiologic neonatal jaundice in which you have a immature UDP glucuronosyl transferase enzyme. Okay, as a result, the unconjugated bilirubin cannot be converted into the conjugated bilirubin. As a result, you will have a high level of unconjugated bilirubin in the newborns, right? It would be caused as jaundice, and because this unconjugated bilirubin is kind of lipid soluble, not the water soluble, it can easily cross the membranes. It can cross the blood-brain membrane, okay, and from the blood-brain barrier, it can easily enter into the brain. In the brain, it can cause the kernicterus, right? Why kernicterus is happening? Because this unconjugated bilirubin is lipid soluble, right? It can easily cross the blood-brain barrier and can enter the brain. There, it can cause a kernicterus. Okay, it is because of a deposition in the brain, right? And the most common location is the basal ganglia. Okay, very important. It generally starts within the 24 hours of the life and resolve without treatment within 1 to 2 weeks. Okay, but the intervention must begin because of the high level of this unconjugated bilirubin that can damage the brain also. Okay, and the treatment includes the phototherapy. You need to prevent the kernicterus from happening. That's why you need to give the patient phototherapy that that isomerize the unconjugated bilirubin to the water soluble form. See, this UV therapy, it is not conjugating the bilirubin, it's just converting the bilirubin into a more water soluble form so that the excretion can be happen from the kidneys. Okay, it is not converting the bilirubin into conjugated form, it's just making it water soluble by isomerizing it. Is that okay?
Yes.
Then comes the biliary atresia, okay, in which you're having a damage of the bile ducts in the newborns. Okay, it is the most common cause of pediatric liver transplantation. Okay, what is happening is the fibro-obliterative destruction of the extrahepatic bile ducts. What does it mean by extrahepatic bile ducts?
Common bile duct and the yeah, the common bile duct.
The common bile duct as well as the right and left hepatic duct. Okay, see, you have the portal triad, right? When the damage is happened to the portal triad, we can call it a intrahepatic damage, right? And whenever the damage happens after the portal triad or before the portal triad, I must say, right, which means the left and the right hepatic duct or the common hepatic duct or any bile duct after that, right? It is known as the extrahepatic damage, right? So in case of biliary atresia, you are having a fibro-obliterative destruction of the extrahepatic bile duct. As a result, you will have a fibrosis in the bile duct, you will have the obstruction in the bile duct, right? And that can cause the cholestasis. Okay, so it will present with the jaundice after 2 weeks of the life. Okay, and the darkening of the urine, because all of the conjugated bilirubin will be leaked out in the circulation, and there it can reach the kidney. From the kidney it would be excreted, right? And but it gives the kidney a very dark color because of the conjugated bilirubin. You will have the alcoholic stools because of the obstruction. This conjugated bilirubin cannot be reached to the GI tract, where it cannot be converted into the sarcobilin, cannot be come into the stools. So ultimately, you will have a very light color stools or a pale colored clay stools. These are known as the alcoholic stools, and you will also have the hepatomegaly, right? So the biliary will be normal at the birth, absolutely normal. Then subsequently, it will undergo the destruction, right? And the destruction could be the autoimmune or could be the viral induced. The specific cause is still unknown why it is happening. It's just happening, right? And the baby will be normal at the birth, right? And the symptoms will only start appearing after 2 weeks. Very important. You will have an absolutely normal baby at the time of birth, right? So for the labs, you will have a direct level of bilirubin will be very high. You will have a high level of GGT because of this biliary atresia. You will have the cholestatic pattern of the liver injury, right? You will have the high level of alkaline phosphate. You will have the high level of GGT more than the ALT and AST, right? And you will have a high level of direct bilirubin. Okay, and yeah, that would be it. What you will see on the biopsy of the patient, the diffuse deposition of the collagen. Okay, whenever you see the biopsy, you do the biopsy of the bile tract. What you will see is the collagen deposition, which means the fibrosis, and this fibrosis will be obstructing the uh, bile ducts. Okay, any doubt?
I have one question.
Ask.
The biopsy which you were talking about, we do the biopsy of the bile ducts or of the liver?
Bile ducts,
Okay. Thank you.
because of this condition is in the bile ducts, right? The liver will be absolutely normal. So, in case of liver biopsy, it will show absolute normal thing. But in case of a biopsy of bile duct, you can see what's happening, right?
Yeah, but you have also written that biliary atresia can cause cirrhosis. So liver damage
Yeah,
may be.
it is in a very late stage, not a very initial one.
Okay,
Okay.
yeah.
It is in a very late stage only,
Okay.
right?
Yeah.
And that's why doing the liver transplantation, right?
Yeah. Okay.
So in the late stage, if we can do the biopsy of the liver, then it will show something. But in the initial stages, the liver would be absolutely normal.
All right. Okay. Thank you.
Okay, now the causes of uh, the conjugated hyperbilirubinemia and again the unconjugated hyperbilirubinemia, right? The Gilbert syndrome and the Kliger-Naja syndrome, these are the causes of unconjugated hyperbilirubinemia. The Dubin-Johnson and the Rotor syndrome, these are the causes of conjugated hyperbilirubinemia, right? So let's discuss about the Gilbert and the Kliger-Naja syndrome. In case of a Gilbert syndrome, you will have a mildly reduced activity of the UTP glucuronidase transferase. As a result, okay, the patient is mostly asymptomatic. Okay, in normal conditions, this enzyme will be absolutely converting, this unconjugated bilirubin into the conjugated form. Okay, so symptoms won't be occur. In case of any kind of stress, like a illness, like a anxiety, or any, any brain symptom, or any kind of fasting, okay, the patient can have a increased level of this unconjugated bilirubin, okay, without any overt hemolysis. So the patient will be absolutely normal. Only in case of any kind of stress, any kind of illness, or the fasting, okay, this will induce the uh, la- uh, high levels of the unconjugated bilirubin. Okay, so it would be a patient with absolutely normal history, but the patient sometimes got the intermittent, or I can say the episodic symptoms of the hyperglycemia, of this hyperbilirubinemia, right? Of this jaundice, right? So that's how you can know the patient is having a Gilbert syndrome. Whenever you encounter a patient with episodic hyperbilirubinemia, that means the patient must be having the Gilbert syndrome, right? And when you check the levels, you will have a high level of unconjugated bilirubin and low level of conjugated bilirubins, right? So how can you differentiate this Gilbert syndrome with, the hemolysis? In case of hemolysis, you will be having the episodic symptoms of the jaundice, right? Because whenever the hemolysis happened, the patient will get a high level of unconjugated bilirubin. And similarly, in case of Gilbert syndrome, the patient will also get the intermittent episodes of unconjugated bilirubin. So how could you differentiate between the Gilbert syndrome and the hemolysis?
In Gilbert syndrome, we'll be probably having normal hemoglobin level.
Well, sometimes in case of the hemolysis, you will also have the normal hemoglobin, this levels of hemoglobin. If the mild hemolysis is there, it won't affect much, right?
Yeah.
Like if I'm having a 15 level of hemoglobin, I can have like 13 or 12, and this would be absolutely normal levels, right? You can't say I'm having a hemolysis in these conditions.
Uh,
So other
or
labs,
increase reticulocyte count, LDH count.
It depends if the hemolysis is because of the because of any bone marrow cause or because of any other cause, right? Again, it depends on situations. You can do that, no doubt. But sometimes you get the positive results, and and sometimes you get the negative results also, right? So any other thing that I can 100% say that the patient is having this hemolysis completely. In case of hemoglobin level, sometimes you can have a low hemoglobin level. You can say that the patient is having a hemolysis, right? In sometimes you can also get a normal levels of hemoglobin, and then you can't say if the patient is having a hemolysis or not. Similar case goes for the reticulocyte count. If the bone marrow compensation is there, if the bone marrow is absolutely normal, then you can get a high level of reticulocytes. If the bone marrow is abnormal, then you can get a low level of this or the normal level of the reticulocytes, right? So you can't say absolutely that the patient is having a hemolysis.
Haptoglobin level?
Haptoglobin level be again depends if it is intravascular hemolysis or the extravascular hemolysis. So again, you cannot be 100% sure. Any other thing? You have one thing common, one lab test which is common for both the Gilbert syndrome and the hemolysis. You can do that test and can determine whether the patient is having a hemolysis or the Gilbert syndrome. Any such tests, if you guys know?
Coombs test?
Comb test again depends if it is because of antibodies or because of any other thing, right? Like glucose 6 phosphate deficiency, it will be negative comb test, right? See, the levels of bilirubin itself tell you whether the patient is having a Gilbert or the hemolysis. In case of hemolysis, you will have a very high level of unconjugated bilirubin as well as the high level of conjugated bilirubin, right? Because your enzymes are absolutely normal. Whenever you have a high unconjugated bilirubin, okay, more unconjugated bilirubin will convert it into the conjugated one, right? And you will have a increased level of both the unconjugated as well as the conjugated bilirubin. Is that okay? In case of hemolysis.
Yeah.
In case of Gilbert syndrome, you will be having a high level of unconjugated bilirubin, but a normal level of conjugated bilirubin, not increased, right? And that's how you know the patient is having a Gilbert syndrome, not the hemolysis. Okay. Even a mildly raised level of conjugated bilirubin will suspect you for the hemolysis, not for the Gilbert syndrome. Okay.
Okay. I have
So
one doubt.
yeah.
Yeah. In case of hemolysis, does both the kinds of bilirubin increase?
Yes. Yeah. Of course.
Because in the previous page you had said that both
See,
the
it depends on the level. It depends on the level. You have a very high level of unconjugated and a very mildly increased level of disconjugated, right?
yeah,
A
okay.
very high increase in the unconjugated and very mild increase, very mild increase. That's why I told you that even if you have a very mildly increased level of conjugated bilirubin, then you will always suspect the hemolysis, not the Gilbert syndrome.
Okay,
Okay.
so it'll be somewhere near, like, if the range is 5 to 10 for conjugated bilirubin, then the range then the level might be around 11 or 10.
Yeah, yeah, exactly.
Okay, got it. Thank you.
That was about the hemolysis and the Gilbert syndrome. So do not confuse. In both the scenarios, you can have a high level of unconjugated bilirubin. So, it kind of sometimes confusing. So you need to be able to differentiate between these two scenarios. Okay. Any kind of stress, any kind of illness, any kind of fasting, it can cause the jaundice episodes. Second is the Kliger-Naja syndrome. Okay, and we've discussed about type 1. It has two types, the type 1 and type 2. For the type 1, you will be having an absolute deficiency of the UDP gluconyl transferase, and as a result, the patient cannot convert the unconjugated bilirubin into the conjugated one. Okay, so this condition will present itself in the very early stage of the life, right? It will be symptomatic in the infants also, right? When the baby is just born, he can present you with the unconjugated hyperbilirubinemia, right? Symptoms include the jaundice, kernicterus. Kernicterus, why? Because of the bilirubin deposition in the brain, right? The patient will have a high level of unconjugated bilirubin, okay? And the treatment you can give first is the phototherapy. Okay, the phototherapy, it won't conjugate the bilirubin, but it will it will convert it into the more water soluble form so that it could be easily excrete from the kidney, right? And the liver transplant is of course curative, very important. Okay, so this is a Klinger-Nacher syndrome type 1. Okay, now then comes a type 2. Okay, that type 2 is kind of, because you know that this enzyme is actually responding to the P450 levels. Okay, it depends, the activity of this enzyme, it depends upon the activity of cytochrome P450. If you have a high activity of cytochrome P450, then this enzyme could be activated much, right? And if you have a low level of cytochrome P450, then it will inhibit this enzyme. So our type 2 is kind of responding to the cytochrome P450 activity, right? So if you give the patient phenobarbital, the phenobarbital is activating the cytochrome P450, which will further activate this enzyme, and this thing could be curative, right? So you have two type of syndromes, so type 1 and type 2. The type 2 is responding to the phenobarbital, but type 1 is not responding to the phenobarbital. In both scenarios, you will have a high level of unconjugated bilirubin that can cause a jaundice, kernicterus, unconjugated hyperbilirubinemia. Is that okay?
Could you please repeat the association between cytochrome P450 and this enzyme?
If you have a high activity of cytochrome P50, then you will have a high activity of UDP glucosyl transferase. If you have a low activity of cytochrome P450, then you will have a low activity of this enzyme. So those drugs which activate the cytochrome P450, like the CNS agents, for example, the phenobarbital mostly, okay, it will activate the cytochrome P50. That means it could activate the UDP glucosyl transferase also. And what you will get is kind of a treatment for the type 2 Crigler-Najjar syndrome. Okay.
Okay, got it. Thank you.
And so now the third one, which is these two are the cause of conjugated hyperbilirubinemia. Okay, for a Dubin-Johnson syndrome and both for the Rotor syndrome, it is kind of an excretion defect. Okay, in which you're forming your liver is absolutely converting the unconjugated bilirubin into the conjugated one, but it can just not excrete these this conjugated bilirubin from the liver, right? So these the conjugated bilirubin will be start depositing in the liver, okay, and it will be leak out. It will go into the blood, right, and it will reach to the kidney, and from the kidney, this conjugated bilirubin will be excreted, and that can cause a very dark urine. Okay, so in both scenarios, you will have a high level of conjugated hyperbilirubinemia, right? And you will have a this alcoholic type of stools. You will have a very dark urine will be there, right? But one thing which differentiates these two conditions is the color of the liver. Okay, in case of Dubin-Johnson syndrome, you will be having a hyperpigmentation of the liver. In case of Rotor syndrome, the liver will be normal. The color of the liver will be normal. Now, why the hyperpigmentation is occurring? Because the epinephrine metabolites, the metanephrine and the normetanephrine and the HMA, VMA. Okay, in case of Dubin-Johnson syndrome, you even cannot excrete the epinephrine metabolites, and as a result, they will be start accumulating within the liver also, along with the bilirubin, right? So they will give the liver a very dark color, hyperpigmentation. In case of Rotor syndrome, it is just the excretion defect of bilirubin, not the other substances. And that means the epinephrine metabolites will be excreting normally from the liver, right? And that's why you cannot have the hyperpigmentation. So this is a difference between the Dubin-Johnson syndrome and the Rotor syndrome. Is that okay?
Yes.
So please remember, if just someone asks you why you are having a very dark color in case of Dubin-Johnson syndrome, because of the epinephrine metabolites, HMA, VMA, metanephrine, and the normetanephrine. It is a complete excretion defect from the liver. That's why we'll have a high level of epinephrine metabolites. In case of Rotor syndrome, it's just an excretion defect of the bilirubin. Okay. So this is a complete cycle, how the bilirubin is formed. You will have the hemolysis. From the hemolysis, the hemoglobin will be released. Okay, it will be converted into the bilirubin, and before the bilirubin, it should convert first into the biliverdin. okay, by the heme oxygenase, and then by the action of reductase enzyme, it will be converted into the bilirubin, right? The bilirubin will be binded to this albumin, right? And it will go to the liver from and inside the liver, this unconjugated bilirubin will be converted into the conjugated form by the action of the enzyme UDP glucosyl transferase. The conjugated one will be excreted into the bile then, right? Very important. And whenever you have some kind of a blend trauma, you will always see this violet or the blue color type of rash over the skin, right? A discoloration of the skin will be there into the bluish or the violet, right? And why this color is happening? Why the discoloration of this skin happening? Because of the bruising, right? It is because of the release of the hemoglobin from the RBCs. When the hemoglobin is released from the RBC, it will be first converted into the biliverdin by the action of enzyme heme oxygenase. And this biliverdin will give the bruise a green color or the blue color that you see, right? So if the step one asks you why you are having a blue or the green color of this bruise, it is because of the biliverdin, which is kind of a green color. Now, by the action of enzyme, the reductase, which is a biliverdin reductase enzyme, okay, this biliverdin will be converted into the bilirubin, the unconjugated bilirubin, and this will again change the color of the bruising, right? So the color changing that you will see in case of bruising, it is because of the uh, uh, it is because of the metabolism of this hemoglobin. Is that okay?
I have one question.
Yes.
Do these reactions occur inside the macrophages or in the extracellular space?
In the extracellular space.
Okay, okay. Thank you.
Okay. So that's a difference upon the this Gilbert syndrome and the hemolysis. In case of hemolysis, you will have a direct level increase, you will have an indirect level increase. In case of Gilbert syndrome, you will have an indirect level increase, but the direct one is absolutely normal. It is a way to differentiate between these two conditions. Okay. Just give me a second. Yeah. Now comes the hereditary diseases of the liver. Okay. The first one is the Wilson's disease. The Wilson's disease is because of the mutation in the gene, which is the ATP7 gene located on the chromosome number 13. Does anyone remember about the ATP7A gene? We have discussed that in the
Mink,
biochem section.
minky kinky hair disease.
Yeah, it is also known as the Menkes disease, right? So in case of a ATP7A disease, sorry, in case of mutation in the ATP7A gene, you will be having a very low level of copper, right? Because the absorption of the copper is not occurring. In case of ATP7B gene mutation, you will be having a very high level of copper, right? So let's discuss this scenario. It is an autosomal recessive mutation in the hepatic copper transporting ATPase, a very important ATPase. Now, the function of this ATPase is to incorporate the copper into the apoceruloplasmin, okay, so that the copper could be transported into your body. Remember, you have a transporters for the ions, like like in case of iron, you will be having a transferrin. In case of copper, you will be having a ceruloplasmin, right? And the ceruloplasmin will first present in the inactivated form, which is known as the apocellular plasmin, right? It would be converted into the activated form when it bind to the copper, and it would bind to the copper with the help of this enzyme, the copper transporting ATPase. Now, as a result, because the copper cannot be incorporated into the apocellular, you will have a very low level of ceruloplasmin and a very high level of copper. Now, second function of this ATPase is to excrete the copper into the bile. Okay, you know that in order to excrete the copper from the body, the 95% of the copper will be excreted from the liver, right? And remaining 10% or 5% is excreted by the kidney. So 95% of the copper will be excreting into the liver with the help of this bile. And you require this enzyme to incorporate the copper into the bile. So if the enzyme is kind of defective, the copper cannot be incorporated into the bile, and as a result, the excretion of the copper is also decreased. So you'll be having a very high, a very low level of a very low level of cytoplasmin and a very high level of copper, right? And this copper then will leak out from the liver, and it will start accumulating into various tissues like the brain, like the liver, like the cornea, like the kidneys, right? And because now the hepatic excretion is now inhibited, the only way for the copper sorry the only way for the excretion of copper is remaining is the kidneys, right? So you will be having a very high urinary copper. Okay, because the kidneys will increase the excretion of the copper. They will be excreting like 20 to 30% of the copper, and as a result, the copper concentration in the urine will be increased. Okay, so a mutation in the ATP7B, which will make this enzyme defective. As a result, the copper cannot be incorporated into the apocytoplasmin as well as into the bile. You will be having a very low level of cytoplasmin. You will be having a very high level of copper, right? The copper will deposit into the liver, brain, kidney, corneas, right? And you will have a very high level of urinary copper. Okay, especially in the brain, this copper will be deposited into the basal ganglia. It is a very special location for the deposition of the copper, the basal ganglia, and the basal ganglia is responsible for the movement in your body, right? So let's discuss the symptoms of this disease. First thing you should note that this disease must be present before the age of 40. While in case of hemochromatosis, this disease will always present after the age of 40. Okay, so Wilson's disease is kind of much more severe than the hemochromatosis. Generally, the teen patients, okay, uh, they can also develop the symptoms like in age of 15 or 16 or 17 years of age. The patient can develop symptoms of the Wilson's disease, right? Because of the deposition in the liver, okay, the patient can get the hepatic cirrhosis. He can get a high level of ALT and the AST, right? Because of the deposition in the skin, the patient can get the hyperpigmentation because of a copper deposition in the skin, right? Because of the deposition in the cornea, the patient can get a special type of ring which is known as a Kaiser flasher ring. Very important. It is because of deposition of the copper into the cornea, right? You will get this kind of the brownish kind of this ring around the eye known as the Kaiser flasher ring, and it is a very highly diagnostic test for the Wilson's disease. For a deposition in the brain, the patient can get the dysarthria, dystonia, tremor, and the Parkinsonism, because you guys know the basal ganglia is very important for the movement. So because of the copper deposition in the basal ganglia, the patient can have a dysarthria, dystonia, tremor, and Parkinson's, the movement disorders. Plus, the patient can also have the neuropsychiatric diseases, anxiety, depression, or ADHD could also be there, right? And you must know the location of this deposition in the cornea. This will be the Descemet's membrane. Okay. The patient can also get the hemolytic anemia. It is also very important. And the patient can get the renal disease. The patient will be having a renal failure also. And does anyone know why the deposition of this copper is causing all these symptoms or the damage to the cell?
Free radicals.
Exactly, free radical oxidation. Okay, don't forget that. You will be having a free radical damage because of this copper deposition, and that reaction is known as the does anyone remember the name of the reaction? The Fenton's reaction.
Fenton
The
reaction.
Fenton's reaction. Yes, exactly. The Fenton's reaction. Okay. So that would be all about the Wilson's disease. You will be having a very liver damage. You will be having a brain damage. You will be having a kidney damage. Okay, and you will be having a damage to the eye. Right. In the liver, it can cause cirrhosis. In the brain, it can cause the psychiatric conditions or the movement disorders. In the cornea, it would be the Kaiser flasher ring. In case of kidneys, it would be a kidney failure, and you will be having a very high level of urinary copper. Any doubt so far on the Wilson's disease?
I have one question.
Yes.
Since the ATPase can't transport copper from the hepatocytes to the blood, then how
Yes.
does copper enter the blood and it leads to deposition in multiple tissues? Is it because of hepatocellular damage?
Yes, exactly. The
Okay,
cells will get damaged and they will release the copper in the circulation.
okay, got it. Thank you.
Okay, now comes the treatment for the Wilson's disease. Okay, you will do the chelation therapy. With the chelation, you can easily excrete the copper. Since the copper is already inside your body, if you give the patient chelation therapy like the penicillamine, okay, the function of the penicillamine is to bind the free copper, okay, and to make it more water soluble, okay, so that it could easily excreted by the urine, right? Then second drug you will have the zinc. Okay, and zinc will chelate the copper in the GIT, and as a result, it will interfere with the absorption of the copper. So if you give the patient a zinc therapy, then you will be decreasing the copper absorption. If you give the patient penicillamine therapy, then you will be increasing the copper excretion. Is that okay?
Yeah.
Can you repeat the process of zinc?
This zinc will bind to the free copper in the GIT. Okay, and as a result, it will interfere with the absorption of the copper in the GIT, and as a result, the absorption of copper will be decreased. Right? In case of penicillamine, it will bind to the free copper and it will increase the excretion of the copper. So if the step one asks you, the patient is giving the penicillamine therapy, right? So what does what does this drug do? Right? So it will increase the excretion. If the step one mentioned about the zinc therapy, then it will decrease the absorption. Very important. Okay.
Okay,
Yeah.
thank you.
Okay. So that's everything about the Wilson's disease. Okay. And yeah.
Uh,
Yeah. Do
I
ask.
have, do we get KF ring in other diseases except apart from Wilson's disease?
No, the KF ring is very specific for the Wilson's disease.
Okay, okay, thank you.
And how will you identify the Keshav Fleischer rings?
Slit
Uh,
lamp.
Slit lamp. Yeah, slit lamp examination. Yes. And one more thing, in the brain, okay, we have discussed that this copper deposit in the basal ganglia, and within the basal ganglia, a very specific location for the deposition of copper is the putamen. Okay, it is the putamen where the copper deposits in the basal ganglia. Very important to note. Okay, and does anyone know what this putamen is actually?
A nucleus in the basal ganglia.
Yeah, of course. Where does it present? I mean, how can I explain this? Uh, see, let me try. This is your thalamus, okay, right? So this is your thalamus, okay. Above the thalamus, you will have the caudate nucleus, right? You will have the caudate nucleus, okay. Then below it, you will be having the hypothalamus and this subthalamus also, okay. And this will be the globus pallidus internus, right? This will be the globus pallidus externa, right? And this will be the putamen here. Okay, this is the putamen. Okay, right? So it is a location where your copper is specifically deposits in case of basal ganglia. Okay,
Okay.
step one sometimes also give you the CT or MRI of the patient brain, right? And they will ask you where does the copper specifically deposit in the brain. So they will mark some A, B, or C or D, and you need to choose the putamen from these options, right? So do remember where the putamen is and where the copper deposits in the brain, right?
Yeah.
Okay, and just give me a second again. That would be it about the Wilson's disease. Okay, now let's discuss the hemochromatosis. In case of hemochromatosis, you will be having a mutation in the HFE gene. And if you guys remember, this HFE gene will be coding for a HFE protein, which will interact with the DMT1 receptors, right? And does anyone remember the function of DMT1?
Absorption of iron from the GIT and
Into
other
the
dividends.
enterocytes, right? So you won't be, if this gene is normal, if the protein is normal, okay, then the iron, whenever the iron overload happened, this iron will be stopped absorbing in the enterocytes, because the function of the HFE is to interact with the DMT1 receptors and to inhibit the absorption of the iron in the enterocytes. Second thing, this HFE protein will also interact with the hepatocytes to increase the release of hepcidin, so that even if the iron is absorbed in the enterocytes, okay, this hepcidin will inhibit the receptor known as the ferroportin,
Ferroportin.
right? So the ferroportin is inhibited, and as a result, the absorption of the iron from the enterocytes to the blood cannot happen, right? So in case of a damage or a mutation to this gene, what's going to happen? The DMT1 will be activated, the hepcidin will be decreased, and as a result, you will have a massive absorption of the iron. And please note, your body has no way to excrete the iron. Okay, it cannot be excreted by any means from the body. Okay, and the only means by which you can get rid of the iron is by the blood loss. Okay, is by any kind of trauma or any kind of blood loss, only you can have the loss of iron. No other means is exist in the body to get rid of this iron. Okay, so yeah, in case of this hemochromatosis, you will be having a mutation in the HFE gene, and as a result, a massive absorption of the of the iron is happening, right? So we'll get a very high level of iron. Okay, you will get a very high level of iron stores, which means the ferritin. Okay, if the ferritin is high, then you will always have a very low level of TIBC, right? You will be having a very high level of transferrin, which will bind to the free iron in the blood. Okay, and because you will be having a very high levels of iron, okay, this transferrin will bind to more iron. Okay, and as a result, the levels of the transferrin is increased. So you will be having a very high level of transferrin. You will be having a very high level of ferritin. You will be having a very high level of iron and a low level of TIBC. This TIBC actually represent the affinity of the transferrin for the iron. In case if you are having a very high level of iron in the body, okay, which means a high level of ferritin, then the affinity will be low for the iron. If you're having a very low level of iron in the body, that means a low ferritin levels, then the affinity of this transferrin for the iron is very much high. So this ferritin and TIBC, they always are opposite to each other. Is that okay?
Yeah.
So please remember the TIBC and the ferritin, they are always opposite of each other. In case of hemochromatosis, for the iron overload, you will be having a very high level of iron, ferritin, transferrin, but a low level of TIBC. Okay. And so this is the first thing for the hemochromatosis. Secondly, the hemochromatosis can also be happen because of a chronic blood transfusion. And the chronic blood transfusion you will be need in the beta thalassemia, right? Like in case of sickle cell anemia also. In these diseases, you will be having a very chronic blood transfusion. And so because of that, you can also have a high level of iron in the body. Okay. And yeah, so these two are the causes for the hemochromatosis. Now, what are the symptoms? Symptoms are because of the deposition of the iron into various tissues, right? In case of, let's we'll discuss these tissues. Yeah. So in case of the skin, you will be having a hyperpigmentation, right? In case of the musculoskeletal, you will be having a high deposition of this calcium in the joints, right? So it can cause the arthritis, it can cause the chondrocalcinosis. And please remember, please note the fact that the arthritis is mostly affect the second and the third metacarpophalangeal joint of your hand. Okay, second and third metacarpophalangeal joints of the hand are specifically involved in the arthropathy or the arthritis because of the hemochromatosis, right? Very important. Okay, so for the GIT, you will be having a very liver damage. For the liver damage, you will be having a cirrhosis, hepatomegaly would be there, high ALT, AST count is there, right? And you can also get the hepatocellular carcinoma. Okay. For the endocrine, you will be having a diabetes mellitus, okay, because of the deposition in the pancreas, right? Second thing, you will also have a deposition of this iron in the pituitary, right? And when the iron is start depositing in the pituitary, it will damage the pituitary, it will causing the hypothyroidism, it will be causing the hypogonadism also, right? So the patient will be having a small testis, infertility could be there, right? And the patient is also having the hypothyroidism. For the deposition of iron in the heart, you can have either the restricted cardiomyopathy or the dilated cardiomyopathy. Okay. So all these symptoms are because of deposition of the iron in the body. For the skin, hyperpigmentation would be there. For the MSK, the arthritis would be there, and this arthritis mostly affect only the second and the third metacarpopharyngeal joint. For the GIT, you'll be having a liver damage. For the endocrine, the pituitary damage and the pancreas damage, right? And for the cardiac, it would be the damage to the heart. And symptoms, they are only present after the age of 40 when the iron levels become more than 20 gram. Then only you can have the symptoms. Okay. And because in case of females, the menstrual cycles are there, which will cause a regular bleeding. So females can get the rate of iron at some way, right? And as a result, the disease will present in very late stages in the females. While in case of male, the disease will become evident, will become symptomatic in age of like 45 or less than 50 years most of the time. In case of females, they will be having symptoms only after the menopause, which is around the age of 55 to 60 years of age, right? So note this fact also. Stephen will ask you why the females having a late progression of the disease. It is because of the bleeding. It is because of the menstrual cycles, right? Not the case of males. So yeah, what you will see on the microscopy, you will see a very brownish deposits in case of H&E stain, right? And then you do the Persian blue staining, and when this when this black and brownish deposits turn into the blue deposits in case of Persian blue staining, that means it is the iron. Because you guys know that age-related senile pigment transthyretin can also present as the brownish deposits, right? But when you do the Persian blue staining, it will always remain brown, not the blue. So that would be the very helpful test, the Persian blue staining for the iron. Okay. And yeah, so doubt about any doubt about the hemochromatosis so far?
I have one question.
Yes.
Is the arthropathy in hemochromatosis the same as pseudo gout? Because in pseudo gout also we get deposition of calcium pyrophosphate.
Yeah, you will be having a deposition of see, location is important. Okay. In case of the hemochromatosis, you will be having a location in the second and third metacarpopharyngeal joint. In case of pseudo gout, you will be having a deposition in the knees mainly, right?
Okay, yeah.
So location is very important. The second and the third metacarpopharyngeal joint is very specific for the hemochromatosis.
Okay.
Okay.
Thank you.
So what is the treatment? Treatment contains the deferoxamine, okay, defepirone, okay, and the Rasirox. I don't know what the name of this drug. Okay, so main drugs are the deferoxamine and the defepirone. Okay, they're again the iron chelating agents. They will increase the excretion of the iron from the body somehow, right? And the second treatment is the phlebotomy, in which you remove the RBCs from the blood. Okay, so as a result, you'll be removing the iron from the blood. Okay, so two treatments exist. One is the phlebotomy, and second is the chelation therapy with the help of deferoxamine and the defepirone. Okay, and these drugs will also decrease the absorption in the GIT. By binding to the iron, they will be increasing the excretion of the iron from the GIT, right? So yeah, and other complications includes increased risk of the listeria, Vibrio vulnificus, and the Yersinia infection. Very important. You will get the infection of Yersinia, Vibrio vulnificus, and Yersinia, because these agents, these organisms, they will feed on the iron stores, right? And if you guys remember from the microbiology sections, we have discussed about the Vibrio vulnificus, how it can have a very mild cellulitis in case of a normal patient, but in case of a patient with any liver disease or the iron overload, the patient can have a necrotizing fasciitis, right?
Yes.
So these agents, these microorganisms, they feed on the iron stores. Okay, so any other doubts so far about the hemochromatosis?
Do we need to remember the carrier frequency or carrier rate of
No, 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 no. Don't worry about that. You won't need to. Remember one thing also, that is a C282Y. Okay, this
Yeah,
thing.
C282
Okay.
mutation,
Yeah.
sense mutations.
Yes. You just remember this thing also. Very important.
Okay. Okay.
Okay, then comes the biliary tract diseases. And yeah, these two diseases, the Wilson's disease and the hemochromatosis, what kind of bilirubinemia, hyperbilirubinemia they can cause?
Unconjugated,
Why unconjugated?
because they'll damage the liver, and since the liver is damaged, it not convert unconjugated bilirubin to conjugated
See, in
bilirubin.
case of cirrhosis and the hepatitis, you will be having a high level of both conjugated as well as the unconjugated bilirubin. Remember the page 393 first aid?
Yeah, yeah, yeah.
So because the ultimate thing is the cirrhosis and the inflammation to the liver, hepatitis and cirrhosis, the patient will be having a high level of conjugated as well as the unconjugated bilirubin. Okay.
Yes.
Okay, now comes the biliary tract diseases. Okay, and these diseases are responsible for the what kind of bilirubin?
Cholestatic.
The conjugated one. Okay, it is kind of an excretion type of defect. Okay, because of the high level of unconjugated bilirubin, the first symptom is generally the pruritus. Okay, even though the jaundice is not present, okay, the patient will get the pruritus first. So a very first complaint of the bilirubin, I can say the hyperbilirubinemia, is the pruritus. Then the patient can also get the jaundice, okay, and the obstructive pattern of liver injury will be seen. The patient will get the dark urine, light colored stools, hepatomegaly would be there, okay, and the patient will be having a cholestatic pattern of liver injury, which means the patient will be having a more alkaline phosphate and the GGT levels than the ALT and AST. Okay, the patient can also have a high level of cholesterol that can promote the xanthoma formations, right? So these are the symptoms you will get whenever you get either of the three diseases. Is that okay?
Yes.
Just remember about the obstructive type of liver damage that would be seen in the biliary tract diseases. The first one is the primary sclerosing cholangitis. As the name suggests, sclerosing would be there. Sclerosis would be there, right? Which is the wall thickening, right? And this wall thickening will be happening in the concentric onion skinning pattern. Okay, this wall thickening will be in the concentric layers, which will make it look like the onion skinning. Remember from the previous lecture we have discussed about this onion skin pattern.
Yeah, hyperplastic
Hyperplastic.
atherosclerosis.
Yeah, so similar kind of findings will be seen in the bile duct in case of primary sclerosing cholangitis. Ultimately, the patient will get the fibrosis, so he will get a very high deposition of collagen also, which will see the patient is having a fibrosis in the bile duct, right? And the stricture formations can happen. And whenever the stricture formations happen, this will block the drainage of the bile, right? And the result, every duct which is before the obstruction, it will become very dilated. You will have the dilation of the intra as well as the extra hepatic bile ducts. Is that okay? And that could be seen on the CT or the MRI of the patient. Yeah.
Yeah.
Okay. So that's about the primary sclerosing cholangitis. Okay. What is epidemiology? Please note that for the step one, this is always going to be a middle-aged man. Whenever you encounter a male patient, okay, with the symptoms of this obstructive jaundice, okay, along with some kind of a damage to the bile duct, that means the patient is having a primary sclerosing cholangitis. He cannot have the primary biliary cholangitis in case of step one. Okay. What are some associated features the patient? Remember, if from the ulcerative colitis part, we have discussed that most of the patients with the ulcerative colitis, they will ultimately get the primary sclerosing cholangitis, a complication of ulcerative colitis, right?
Yes.
So the patients are also got the ulcerative colitis, right? The patient can get the P-ANCA positive. Okay. They will have a high level of the IgM antibodies. And very important, the patient will also get the increased risk of cholangiocarcinoma. Okay, the patient will get the increased risk of cholangiocarcinoma and the gallbladder cancer. It is very important. Okay. So that's about the primary sclerosing cholangitis. See, you will get the sclerosis, you will get the onion skinning, you will get the fibrosis, you will get the uh, is- the formation of strictures. Okay, so ultimately you will be having an obstructive pattern of liver injury, along with this these associated features like the ulcerative colitis, PNK, and the IgM, and the increased risk of cancer. Is that okay about the primary sclerosing cholangitis?
Yes.
Then comes the primary biliary cholangitis. It is a type 4 hypersensitivity reaction. Okay, in this case, you will see the formation of granulomas. And because surrounding the granuloma will be the lymphocytes, so you will see the lymphocytic infiltrate, you will see the granuloma, you will see the destruction of the lobular bile ducts. Okay, and it is only seen in case of middle-aged women. In case of step 1, for the case of primary biliary cholangitis, it is always be a middle-aged woman, not a man. Okay, very important. And the first symptom is usually the pruritus. Okay, the patient can get the anti-mitochondrial antibody. Very important. Remember one more antibody we have discussed previously in case of liver damage?
Smooth muscle
Yes, anti-smooth muscle antibody. See, the anti-smooth muscle antibody is for the autoimmune hepatitis, and the anti-mitochondrial antibody is for the primary biliary cholangitis. Do not get confused, right? You will get the high level of IgM antibodies. Okay, and these can also be associated with other autoimmune conditions, also like the Hashimoto thyroiditis, celiac disease, rheumatoid arthritis, or any other disease. Not just these three, but other diseases also. So whenever you encounter a patient, a female patient, okay, having a history of some kind of autoimmune disorder, and now she's having a pruritus, okay, along with the granuloma formation, that means the patient is having a primary biliary cholangitis. Very important. It is always going to be a case of female patient, not a male patient, right? And yeah, that would be all about the primary biliary cholangitis. Then comes the secondary biliary cholangitis, okay, which is the extrahepatic bile duct obstruction, right? And as a result, because of the obstruction, you will have an increase in the pressure in the intrahepatic bile ducts also, that can lead to the injury, fibrosis, and the biliary stresses. Okay, it is uh, it is only seen in the patients that are having any kind of obstruction. For example, the primary sclerosing cholangitis, okay, any gallstones, any biliary strictures, pancreatic carcinoma. So any kind of thing which is blocking your extrahepatic bile duct, it can increase the pressure in the intrahepatic bile duct also, and that can cause the damage to the liver. Okay, and that can cause a secondary biliary cirrhosis. Okay, which means secondary to any biliary disease, the patient is having a cirrhosis. Is that okay?
Yes.
Yes. And because the obstruction is there, right? So because of the obstruction, the infection can also happen, right? And that's why these patients, they generally present with the ascending cholangitis also. Okay. Yes.
Could you please repeat this thing?
Because of the obstruction, whenever an obstruction is there, okay, then bacteria can easily colonize that area, right? And they can cause the cancer, they can cause the infection. Is that okay?
Yeah, okay.
In case of secondary biliary cirrhosis, because you're having an obstruction, infections can also happen, right? And they can lead to the ascending cholangitis. Okay, important thing.
Cholangitis simply means that the biliary tract is infected.
Yeah, bile duct. Okay. In
Okay.
case of cystitis, you will be having an inflammation in the cystic duct, which is for the which is kind of originating from the gallbladder and will be mixing with the bile duct ultimately, right?
Yeah.
So
Okay.
cystitis means the inflammation of cystic duct, and the cholangitis means the inflammation of bile duct.
Okay, got it. Thank you.
Okay, so that's about the biliary tract diseases. Okay, and because of the obstruction, you can also get a deficiency of fat soluble vitamins, the vitamin A, D, E, K. Okay, so note that fact also. You can get the deficiency of vitamin A, D, E, K, as well as the fat malabsorption would be there in case of obstructive pattern of liver injury. Is that okay?
Yes.
Yes, sir. I was just confirming. Secondary biliary cirrhosis has
Yes.
no autoimmune condition, correct?
Has.
Secondary biliary cirrhosis, there's no
Yes.
autoimmune focus of it. It's purely like something external is causing the
Yeah,
damage.
exactly. It is secondary to some kind of a obstruction or something like that. Okay.
Okay, thank you.
Because of the obstruction, we will be having a very high pressure, and that high pressure can cause a destruction of the intrahepatic ducts. Any kind of obstruction, right?
High pressure meaning that your liver is still functioning or the gallbladder is still releasing?
Sorry, I didn't understand.
High
Repeat it
pressure.
again.
What does high pressure mean?
If you have a blockage, then the pressure before the blockage will be rise, right? The bile is present, the bile will be start accumulating, and because bile is a liquid, right? So you will be having a very high pressure also, right?
Okay. Okay.
And as a result, it will be destruction of the ducts, right? And that can lead to the cirrhosis ultimately.
Thank you.
Any more doubt on this page?
No, thank you.
Okay, so we will take a short break and then meet up again. Okay.
Hi. Yeah, walking.
Let's discuss the gallstones and the gallstone related pathologies. Okay, the complications, you can say. So first thing is the gallstones. You have two type of stones. Okay, one is the cholesterol stones, and second is the bilirubin stones. Okay, or you can say the pigmented stones. So the cholesterol stones and the pigmented stones are the two type of stones. Why the stone formation occur? See, you have the bile salts, right? Whenever the amount and the function of these bile salts is to solubilize the bile, right? Whenever you have and not just the bile and as well as the cholesterol also, right? The bile and the cholesterol will be solubilized by the bile salts. Whenever you have a low amount or a low concentration of the bile salts and a very high concentration of cholesterol and the bilirubin, then you can have a formation of stones. Okay, whenever the bile salts are super saturated with either the cholesterol or the bile, oh sorry, or the bilirubin, okay, then the stone formation occur. Okay, for the formation of bile salts, okay, the rate limiting step will be the cholesterol 7 alpha hydroxylase. Okay, and some drugs can inhibit this enzyme and they can cause a stone formation by decreasing the level of bile salts. Okay, so now let's discuss the type of stones. So the first type is the cholesterol stones. Okay, these are radiolucent, which means if you do the X-ray or any kind of radiological examination, you cannot detect these salts. Sorry, these stones. Okay, very important. And sometimes 10 to 20% times, because they can be calcified sometimes, and because of the calcification, up to 10 to 20% of time they can become radio opaque also, which means you can detect them with the help of X-ray or some other tests. Okay, now the associations. First is the see, this stone formation always occur whenever you have a high cholesterol level or a low bile salt level, right? So the first thing would be the obesity, like the metabolic syndrome. Okay, second thing is the Crohn's disease. You guys know, in case of Crohn's disease, what is happening? The loss of bile salts because of loss of enterohepatic circulation. Okay, and the second thing would be, in case of Crohn's disease,
Ileal resection.
exactly. So you will be having a very low level of bile salts, and they can become super saturated with the cholesterol. They can cause the cholesterol stone formation. Third thing would be the advanced age. With the aging, the chances of being having a stone will be increased. With the estrogen therapy, because you guys know that the estrogen can do what does this can do. This
Cholesterol
estrogen,
synthesis.
exactly. This estrogen can increase the cholesterol synthesis, right? So if you have a high estrogen levels, then more cholesterol will be formed in your body, and as a result, you can have a cholesterol stones. Okay, multiparity can do that. Okay, why multiparity?
Estrogen increases
Because
because of estrogen.
estrogen, yeah, one cause. Another cause,
The chance of increase in the amount of fat inside the body increases.
no, that
Gallbladder
contribute but a very
hypomotility.
minor. Yeah. Say it again.
Gallbladder hypomotility because of progesterone.
Yeah, exactly. Because of high level of progesterones, it will cause the gallbladder hypermobility, and because of high level of estrogen, it will cause the very high level of cholesterol. So because of low mobility and high level of cholesterol, that can cause the cholesterol stone formations. So multiparity is a very important cause for the cholesterol stone. For the rapid weight loss, okay, you will be mobilizing the cholesterol stores in the body. Okay, and because of that, sometimes the bile salts can become super saturated with the cholesterol, and that can cause the cholesterol stone formation. Native American origins, okay, the Americans, they mostly have the radiolucent stone or the cholesterol stone, while the whole world, the other areas, right, they will mostly have the pigmented stones. Okay, so very important, the cause of these cholesterol stones. Please note why the causes are there. Okay, what's happening in every cause, in case of obesity, in case of Crohn's disease, in case of age, in case of estrogen, multiparity, weight loss, and other things, right? So these are all the causes of cholesterol stones. Now comes the pigmented stones. Pigmented stones occur whenever the bile becomes super saturated with the bilirubin, right? And these stones are radio opaque. Okay, they will be having a calcium deposition, so you can easily detect them with the help of X-ray. If you do the X-ray, you can easily detect the presence of these stones. They can be associated with the Crohn's disease, because in case of Crohn's disease, you'll be having a loss of bile salts. Okay, the chronic hemolysis can do that, because in case of chronic hemolysis, you will be having a high level of unconjugated and the conjugated bilirubin that can supersaturate the bile. Okay, other thing would be the infection, because in case of infection, you will be releasing the beta glucuronidase enzyme. Okay, uh, like the E. coli or the liver flu, these organisms release the beta glucuronidase, right? And as a result, some amount of conjugated bilirubin will be converted into the unconjugated bilirubin. Okay, and that unconjugated bilirubin will be causing the stone. Okay, very important. Whenever you have a pigmented stone, it is because of the unconjugated bilirubin levels, right? In case of infection, because of the enzyme beta glucuronidase, this conjugated bilirubin will be converting into the unconjugated form, and as a result, the stone formation occur. In case of hemolysis, because you are having a too much level of conjugated bilirubin, a small amount of, like 1 or 2% of this conjugated bilirubin will always convert into the unconjugated form with the help of this enzyme again, the beta glucuronidase. If you're having a too much high level of unconjugated bilirubin, then more unconjugated bilirubin converted into the this conjugated form, and as a result, the patient can have a stone in case of infections also. Oh, sorry, in case of hemolysis also. In case of alcoholic cirrhosis, you will be having a high level of unconjugated as well as conjugated bilirubin, if you remember. So they can cause the this pigmented stones, right? Give me a second. So they can cause a stone formation, right? Similarly, any biliary infection we have discussed, they can cause the pigmented stone formation. Advancing age can cause the pigmented skin formation, stone formation, right? And the total parental nutrition. And why does the total parental nutrition can cause the stone formation?
Gallbladder hypomotility.
Again, the gallbladder hypomobility, because the CCK hormone won't be releasing if you give the patient IV nutrition, right? And as a result, the patient can get the stone formation. Any doubt about the causes of these stone?
I have a doubt. I'm
Yes.
not getting why do we have different color of pigmented stone? Like, is it because if it is because of unconjugated bilirubin, as in
Yes.
chronic hemolysis, we get brownish discoloration, while
Yes,
we get
exactly.
black discoloration in case of infections. So
Yes. It is because of the
is
enzyme
it
level. In case of this, in case of infections, you will be having a very high level of this beta glucuronidase, right? So more of the bilirubin will be there, right? And that can cause these kind of stones, the brown stones, right? In case of hemolysis, the enzyme level is kind of normal, okay? But what's happening ultimately, because you're having a too much high level of disconjugated bilirubin, okay? So this conjugated one will be converting into the unconjugated form, and that will giving a black color. Okay. See, normally
so
2 to 5%, I think, I'm not remember the exact number, but sometimes 2 to 5% of the bilirubin, the conjugated one will be converted into the unconjugated form. It is normal, right? But if you're having a too much level of conjugated one, okay, then 5% will be converted back into the unconjugated bilirubin,
unconjugated.
right? And that will supersaturate the bile with the unconjugated bilirubin, and that can cause a stone formation.
So basically, we have the colored stone because of unconjugated bilirubin, right?
Yes.
It's basically the amount of the enzyme that is
Yes.
responsible for
Yeah. Amount
or
of enzyme is responsible. Amount of bilirubin is responsible. Amount of conjugated bilirubin is also responsible. Right. Many factors are there for the color. Okay. How much the conjugated bilirubin is in the stones? How much the conjugated bilirubin is in the stones? Right. And how much the activity of the enzyme was. So all of these things can contribute in the color formation. Right.
yeah, right. Thank you.
Uh, could you please explain why
Crohn's is causing pigment stones also?
Because you're having a low level of bile salts. If you're having a low level of bile salts, then doesn't matter if you're having a normal level of cholesterol or the bile or this bilirubin, right?
Okay, so
Both
decreased bile.
stones can happen.
Okay, so decreased bile stones will lead to increase in cholesterol stones as well as pigment
Yeah,
stones.
exactly.
Okay, thank you.
Okay, and one more therapy, the fibrates. If you give the patient fibrates therapy, in that case, you will be inhibiting the enzyme 7 alpha hydroxylase, the cholesterol 7 alpha hydroxylase. And as a result, you can have a cholesterol stone formation also. Okay, this is another important cause. I think FA didn't mention it here, right? Yeah, FA didn't mention here about that. But yeah, fibrate therapy, if you guys remember from the previous lecture, we have discussed how the fibrates can cause the stone formation, right? By inhibiting the enzyme cholesterol 7 alpha hydroxylase. So as a result, the bile formation is inhibited and the patient can get the stone formation also. Okay, as an important thing. And it is mainly the cholesterol stones in the body. Okay. Any doubts so far?
I had one thing.
Yeah.
So progesterone is going to increase mobility, right? So if I,
Progesterone,
yeah,
progesterone decreasing the mobility, not the increase.
okay, that makes much more sense. Thank
Yeah.
you.
Progesterone always decrease as smooth muscles mobility. Okay, so in case of the GIT, the patient can have a constipation. In case of gallstone, the patient can in case of a gallbladder, the patient can have a stone formation, right? And in case of blood vessels, the patient can have a vasodilation, right? In case of sphincters, the patient can have a low sphincter tone that can cause the GERD even in case of pregnancy. Is that okay?
Oh, okay. No, I see what you're saying now. Okay.
Yeah. So for the gallstones, remember the female, fat, fertile, 40. Well, you don't actually need to remember all of these things. Just remember the causes. We have discussed every cause in detail, right? And then comes the complications of these gallstones because you're having an obstruction, right? Because of the obstruction, you can have an infection, right? So it can cause the cholecystitis. Okay, if the stone is in the cystic duct, if the stone is in the main duct, the bile duct, the common bile duct, then patient can also have the ascending cholangitis also, right? If this stone blocks the ampulla of Vater, okay, then the patient can also have the pancreatitis along with the cholangitis, right? And how will you diagnose the condition? You will diagnose with the help of ultrasounds. Ultrasound can show you the stones. X-ray can help. Okay, in case of a pigmented stone, if you do the X-ray, you can easily detect the presence of stones, right? And what is the treatment? Treatment with the elective cholecystectomy if symptomatic patient. Only in the symptomatic patient, you will do the cholecystectomy. Okay. Any doubts so far?
No, thank you.
Okay, so that's all about this paragraph. You need to remember the two type of stones, why the stone formation is occurring, the risk factors, right, the complications and the treatment. Now let's discuss the complications. Whenever you have a this stone in the gallbladder, okay, and whenever you eat a food, the CCK hormone will be released, right, and the CCK hormone will causes the gallbladder contraction, right? So whenever the gallbladder contraction occur and the stone is already present in the cystic duct, okay, this will cause an increase in the pressure in the gallbladder, right? And whenever the pressure in the gallbladder is increased, what's going to happen? The blood supply of the gallbladder will be compromised. The patient can get a ischemia, hypoxia, right? So whenever, in case of a gallstones, what's going to happen? Whenever the patient eat food, okay, they will be having a dull right upper quadrant pain because this is a location of the gallbladder. The patient can also get the nausea, vomiting. Okay, why is it happening? Because of the CCK hormone release. Okay, that triggers a gallbladder contraction so that the force, to force the stones into the cystic duct. Labs are absolutely normal. Why? Because only when you are having a damage to the main duct or the common bile duct, you can have a high level of alkaline phosphate or the GGT. In case of cystic duct damage, the level of alkaline phosphate or the GGT will be absolutely normal. So this is a biliary colic. Is that okay?
Yeah.
Why is it happening? Because of a stone in the cystic duct. Now, because of the second thing, first we have discussed about the biliary colic, which is stone in the cystic duct. Now let's discuss a scenario of the stone in the common bile duct. Okay, whenever the stone is present in the common bile duct, the patient can have a high level of alkaline phosphate and the GGT. Okay, ALT and AST levels are also rising, right? But this alkaline phosphate levels and the GGT levels are more than the ALT and AST. Why? Because of the cholestatic patterns of the liver injury, right? So whenever you encounter a patient having a high level of alkaline phosphate and the GGT more than the ALT and the AST, that means the patient is having a damage of the bile duct, a common bile duct or the intrahepatic type ducts. Okay, and you will be having a direct level of bilirubin very much high. Okay, and yeah, so that's about the choledocholelithiasis. So a biliary colic means stone in the cystic duct, and choledocholelithiasis means a stone in the common bile duct. Is that okay?
Yes.
And whenever you have a stone in the common bile duct, the patient can have a high level of these enzymes. In case of cystic duct, these enzyme levels are normal. Otherwise, the symptoms would be same. The patient can get a right upper quadrant pain, nausea would be there, vomiting would be there, right? And this pain will generally happen after a fatty meal. Symptoms are absolutely normal. It's just a lab values which you will check. Okay. So we have discussed the stones, the type of stones, okay, where the stones can lodge. Okay. Now, if the biliary colic is present, which means our duct is blocked, the cystic duct is blocked. Okay. Now, before the blockage, okay, the patient can also get the inflammation of the cystic duct and the gallbladder. Okay, and the inflammation can happen because of two things. First is the infection by the bacteria. Okay, because a normal flow of this bile is responsible for the clearance of the bacteria, right? If the obstruction is there, then before the obstruction, bacteria can co-colonize, right? And they can cause the infection. Second thing, because of the obstruction, the pressure will be increased in the gallbladder and that can cause ischemia, necrosis, and inflammation. Okay, and all of these things can lead to the cholecystitis, which is the inflammation because of the stones. Okay, it could be acute infection, it could be a chronic infection or inflammation, right? First, let's discuss the calculus cause of cholecystitis, and then we discuss the acalculous cause of cholecystitis. The calculus one is the most common type. It happens whenever stone is present in the cystic duct. Okay, and as a result, the inflammation of the gallbladder is happening, right? And how will you see that? It will be visible as the gallbladder thickening. Okay, and secondary infection can also occur, right? So this is about the calculus cholecystitis. Then comes the acalculous cholecystitis, which happens because of the hypoperfusion and the infection. Okay, it happens due to the gallbladder stasis. Hypoperfusion, which means a patient who is having a dehydration or a shock sometimes, right? Or a patient with sepsis or any trauma, like a hemorrhage, okay, or a patient with the burns. Okay, so mostly this acalculous type of cholecystitis, it happens in the patient within the hospital, right? Maybe with the history of sepsis, maybe with the history of burn or any kind of hemorrhage, right? Or they can also have an infection with the cytomegalovirus, and generally this infection happens in the immunocompromised patients. So whenever you encounter a patient with sepsis, burn, trauma, or immunocompromised status, they can have a acalculous type of cholecystitis. Is that okay?
Yeah.
So we have discussed the cause of cholecystitis, the acalculous one and the calculus one. Now let's discuss the symptoms. Symptoms will be again the right upper quadrant pain would be there, and because the inflammation is here, the patient can also get the fever, right? So fever, right upper quadrant pain, nausea, vomiting would be there to the patient, right? And they have a specific type of pain. This pain will radiate to the right shoulder. This is very important because of the irritation to the phrenic nerve. The pain can radiate to the right shoulder also, right? And another thing would be the Murphy's sign. Okay, it happens because whenever you palpate the right upper quadrant of the patient, because of a very severe pain, they will get the inspiratory arrest. Okay, so whenever you encounter a patient having abdominal pain and you palpate the right upper quadrant and suddenly the patient is having a respiratory arrest, that means he is having a positive Murphy sign, the patient is having a cholecystitis. Okay, and if after the cholecystitis, if the common bile duct is also involved, that means the patient is having ascending cholecystitis. In that case, the patient can have a high level of alkaline phosphate and the GGT. But in case of cholecystitis, the patient is having a normal level of alkaline phosphate and the GGT. Okay, no enzymatic levels are rising. Is that okay?
Yes.
So that's about the cholecystitis. Now let's discuss how you diagnose this condition. This condition will be diagnosed better with the ultrasound. In the ultrasound, you will look for the wall thickening, not the stone formation. Okay, if the stone is even present, that doesn't mean the patient is having an inflammation always, right? So a presence of stone in the gallbladder doesn't comply the patient is having an inflammation. Only if you see a wall thickening in the gallbladder, that means the patient is having an inflammation. It is very important. They will mention you these options. Okay, they will mention you, more than one option about the ultrasound, mentioning that the patient is having a stone in the, which is seen in the ultrasound, or the patient is having a wall thickening in the ultrasound. So you will choose the wall thickening, not the stone presence, right? Second thing is the Hidai scan. Okay, in the Hidai scan, you will inject some dye and you will see where the dye goes. Okay, if the dye goes to the gallbladder, that means it is a normal scan. The patient is not having any kind of inflammation. If the gallbladder is not visible, which means the dye do not goes to the gallbladder, right? That means the patient is having an inflammation. So a failure to visualize the gallbladder on the HIDA scan suggests the obstruction, and that means the patient is having a inflammation also. So the HIDA scan is very important, and the ultrasound. These two things you will do for the diagnosis of cholecystitis. Okay. Yeah, that's all about it. Now, then we discuss the complication. Sometimes what happens because of the inflammation can become transmural. Okay, and there's a fistula formation happens between the gallbladder and the duodenum. Now, because of this fistula, the stone which is present in the gallbladder, okay, they will be leak into the duodenum, right? They will travel all the intestine and finally reach at the ileocecal junction. And this ileocecal junction is actually the narrowest part of your GIT, okay, or the ileocecal valve. It is the narrowest part in the GIT. And at that point, the gallstones will become lodged. And because they are lodged there, they will cause the obstruction in the GIT. The patient can have a abdominal distension, constipation, nausea, vomiting, right? And apart from that, when you visualize the patient X-ray, you will see the air in the bile tree, because there's a connection happened between the GIT and the this bile tree. The air will be leaked into the gallbladder and into the biliary tract, right? So you will see the free air within the biliary tract. Okay, and the patient with the history of with the signs and symptoms of the obstruction like the nausea, vomiting, constipation, and abdominal distension, you will know that the patient is having a gallstone ileus. Okay, so yeah, please note where the formation of this fistula happen and where the stones are lodged, right? Any doubt on that?
No,
Um,
thank you.
Yes, ask.
the thickening of the gallbladder for the HIDA scan, is that
Yes.
also thickening, or are we also having like the calcium deposits as we see in porcelain gallbladder?
Where?
Okay, when we're talking about the HIDA scans, right? You
Yes.
take a scan, and if we see gallbladder stones or the gallbladder, that means we're okay. If we do not see it, that means that there is thickening, right?
Obstruction present. That means yeah, that means the obstruction is present, right? And the obstruction could be it could be due to the wall thickening. It could be due to the presence of stone.
Okay,
Okay.
this is not to be confused with the porcelain gallbladder, correct?
In case of porcelain gallbladder, you can have a positive scan, I think, normal scan, because the gallbladder could be still visualized, because the dye will go to the gallbladder still.
Okay.
Only in
Okay.
case of any obstruction which which is blocking the passage of this dye into the gallbladder, then you can have a negative test. Okay.
Oh, okay. That makes sense. Thank you.
Yeah, you need to visualize a gallbladder, which means a dye must go inside the gallbladder first.
Okay, this is like a radio dye, right?
Yeah, exactly.
Okay, thank you.
Okay. Yeah. So please remember, you will have a raised level of alkaline phosphate and GGT only when the common bile duct is involved. So up to the cystitis, you will be having a normal level of all these enzymes, right? But the this pain and this Murphy's sign, okay, and the right shoulder pain, right upper quadrant pain, nausea, vomiting, it is all common. Okay. Yes. So let's discuss the other pathologies. So we have discussed up to the cystic duct. Now let's discuss about the common bile duct. So when the common bile duct is involved, we call it the ascending cholangitis. Here, we call it the ascending cholangitis, which is the infection of the biliary tree. Okay, the most common cause is of course the obstruction. Whenever you have a stone in the common bile duct, it can cause the infection. The superimposed infection is known as the ascending cholangitis. Okay, so you will see the charcot triad in it. The charcot triad is basically the jaundice, fever, and the right upper quadrant pain. Okay, whenever you got a patient with the jaundice, fever, and the right upper quadrant pain, that means the patient is having a charcot triad, which means the patient is having a ascending cholangitis. Sometimes the pentad is also there along with the fever, jaundice, and right upper quadrant pain. The patient can also get the sepsis. Okay, because it is a bacterial infection, bacteria can gain the access to the blood. Okay, the patient can also get the septic shock. Okay, and the altered mental status. If the septic shock is there along with the right upper quadrant pain, okay, and the jaundice is there, that means the patient is having a ascending cholangitis. It is very important. Okay, and uh, yeah, so fever and right upper quadrant pain, this is seen in both in case of cystitis as well as in the cholangitis. Okay, but jaundice is a very specific to the cholangitis only. Okay, this is an important thing. Take home point. Whenever you see the patient with the right upper quadrant pain and the jaundice, okay, this means the patient is having a ascending cholangitis, not a cholecystitis. Apart from that, if the patient also having a sepsis, okay, and the shock, that means the patient must be having the ascending cholangitis, not a cholecystitis. Is that okay?
Yeah.
And so step one can also ask you what are the protective mechanisms against the bacterial infection in the bile tract. So this is a sphincter of the aorta first. Second is the bile salts. Because of the high concentration of the salts, the bacteria cannot survive these harsh conditions. They will die. Okay. Third thing is a downstream flow of the bile, right? And fourth is the IgA secretory antibodies. These four are the protective mechanisms against the infection within the bile tract. And does anyone remember the bacteria which colonized the this bile tract?
Salmonella.
Salmonella. Okay, it will become latent in the bile tract. Please note that fact. Okay, and so yeah, that's everything about the ascending cholangitis, which is an infection because of obstruction in the common bile duct. Let's discuss about the porcelain gallbladder. Okay, it is just the calcification of the gallbladder due to the chronic cholecystitis. Okay, whenever you have a case of a chronic cholecystitis, the gallbladder will become very thickened and very calcified. Okay, a non-functional type, and it is known as a porcelain gallbladder. This condition is absolutely asymptomatic. It is generally an incidental finding on the chest X-ray or any kind of imaging like CT, MRI, or the ultrasound. Okay, you always need to do the prophylactic cystectomy in this case. Even though the patient is asymptomatic, you need to remove the gallbladder. Why? Because of an increased risk in the adenocarcinoma of the gallbladder. This is very important. This is the adenocarcinoma of the gallbladder, not the cholangiocarcinoma. Okay. You can also have a cholangiocarcinoma, which is a cancer of the biliary tract or the bile duct. Okay. But the gallbladder adenocarcinoma is the cancer of the gallbladder only, right? And does anyone remember the cause of this cholangiocarcinoma?
Primary sclerosing cholangitis.
Yes, and the cause of this gallbladder adenocarcinoma is the chronic cholecystitis and the porcelain gallbladder. Is that okay?
Yeah.
So whenever step one shows you a gross picture of any gallbladder which is very much thickened and fibrosed, okay, that means they are showing you the porcelain gallbladder. Okay, so make sure you see 3 to 4 pictures of this porcelain gallbladder. Okay, they can show you these pictures. So that's all about the gallstones. Now the other thing, which is the cholangiocarcinoma. Okay, and this carcinoma is the cancer of the bile tract or the biliary duct. Okay, so the most common risk factor for this cholangiocarcinoma is a primary sclerosing cholangitis. Okay, and mostly the patient will be asymptomatic only when the tumor becomes so much advanced. Okay, then the patient will have the symptoms, and the symptoms generally includes the obstructive type symptoms, which means a nausea, vomiting, right? And just like any other cancer, the patient can have a weight loss, fatigue, anorexia. Okay, and because the bile tract is involved, the patient can also have a right upper quadrant pain, right? And because of high level of bilirubin, the patient can also have the pruritus. So the obstructive symptoms will be there, and the symptoms of cancer will be there. Obstructive symptoms they include the pruritus, right upper quadrant pain, nausea, vomiting, jaundice, hepatomegaly. Okay, and the symptoms of any cancer it includes a weight loss, fatigue, okay, and the anorexia. Okay, and because a blockage is there, the pressure will be increased in the gallbladder, and you can even palpate the sometimes gallbladder. This is also a symptom, right? For a lab examination, because the bile ducts are involved, the patient can get a cholestatic pattern of the liver injury. That means the patient will be having a high level of alkaline phosphate. Okay, and whenever you have a high level of alkaline phosphate, you always need to check for the GGT levels. The GGT level will always rise. Okay, the conjugated bilirubin will be there in a very high amount because of a obstruction in the bile passage, the obstruction in the passage of bilirubin. Okay, so these are the laboratory examinations. On the imagings, you can do the CT scan. On the CT scan, you can see the dilated intrahepatic ducts because of a blockage. The pressure in the intrahepatic ducts will be increased, and that can cause the and that can be seen in the CT scan also, right? So a dilated bile duct in the absence of any gallstone suggests you the cancer pathology, right? And generally, this cancer is present at the confluence of the right and the left hepatic duct, which means the point where the left and the right hepatic duct meet to form the common bile duct. This cancer generally present at that point. Okay, so you won't be see any union of these ducts. Okay, on the imagings. So this is also an important diagnostic thing. Okay, the most important thing that you can do to diagnose a cancer is the histology, of course. You will take the biopsy of the specimen. On the biopsy, what you will see the columnar cells, because the bile ducts are made up of columnar cells. So you will see the columnar cells. Adenocarcinoma would be there, and the mucin production is there. So a mucin production, the columnar cells, adenocarcinoma, right? This is all about the cholangiocarcinoma. Is that okay?
No, sir. I am confused actually. The cholangiocarcinoma is a type of adenocarcinoma?
Yeah, it is a type of adenocarcinoma. Okay, but it is a cancer of the bile duct. Okay, but in case of the this gallbladder adenocarcinoma, it is a adenocarcinoma from the gallbladder itself. You might be confusing it with the this gallbladder adenocarcinoma, right?
Yes. Can you repeat what you just said?
In case of porcelain gallbladder, you will be having a carcinoma from the gallbladder.
Okay.
Okay. In case of cholangiocarcinoma, the cancer is arising from the this bile ducts, not the gallbladder.
Okay. So when we talk about primary sclerosing cholangitis, is this
Yes.
what
Yeah.
we're talking about?
Yeah. This is a cancer of the which happens from the primary sclerosing cholangitis, right? A cancer of the bile tract, bile duct, right? But in
Okay.
but when we talk about the porcelain gallbladder, we're talking about the gallbladder adenocarcinoma, which means a cancer from the gallbladder itself.
Okay. And then
Okay.
when we on the first aid, it says that primary sclerosing cholangitis leads to both cholangiocarcinoma and gallbladder cancer. So this can happen in both cases, but these are two
Yeah.
separate.
Yeah, two separate things are there, right?
Okay, thank you.
Okay, so any more doubt about it?
No, thank you.
Okay. Okay, so now let's discuss about the pancreatitis, the acute pancreatitis and the chronic pancreatitis. Okay, the acute pancreatitis is the acute inflammation of the pancreas. The symptoms will be very much acute. They will present you within the 1 or 2 days. Okay, the patient will be present you in the emergency department within 1 to 2 days of the symptoms only. Okay, and let's discuss the cause of this acute pancreatitis. It is because of the auto-digestion of the pancreas by the pancreatic enzymes. Okay, in pancreas, you will have the proteases, you're having the lipases. Okay, whenever the lipases or these proteases start digesting the pancreatic parenchyma, okay, you will have the inflammation of the pancreas, right? And that can cause the acute pancreatitis. For example, let's say if you're having a very high level of these triglycerides, right? So you have a lipases in the from the pancreas, right? And these lipases can feed on the triglyceride level to release the free fatty acids. Is that okay?
Yes.
And when the lipases feed on this uh, when the lipases feed on this free fatty on these triglycerides and release the free fatty acids, what gonna happen, this free fatty acid will cause the inflammation, right? And because of the inflammation, sometimes what happens is, the proteases will become activated too. And when the proteases become activated, because all of the parenchyma of the pancreas is made up of the protein, right? They will start digesting the pancreatic parenchyma, right? And they can cause the acute pancreatitis. Okay, so because of the lipases, you're first having a triglyceride digestion, which release the free fatty acids, right? And this free fatty acid will cause the inflammation that will activate the proteases, and these proteases will cause the acute pancreatitis. So the activation of proteases ultimately is causing the acute pancreatitis. Okay, and because the free fatty acids are released, they will get combined with the calcium by the reaction saponification, and they will start depositing on the tissues, right? So we'll see the calcium deposits also, right? So that's about the acute pancreatitis. The activation of enzymes, the proteases, is causing this. Is that okay?
Could you please repeat what you said about calcium deposition?
If you remember saponification reaction, if you're having a free fatty acid, they will always combine with the calcium, right?
Yeah.
So they will form the calcium stones, kind of substrates, right? The calcium and the fat substrate, and they will deposit on the tissues, which can be seen on the imagings, also the chest X-ray and other things. Abdominal X-ray, not chest X-ray. Abdominal X-ray and other things also, right?
Okay. And these deposits occur in the pancreas or in other tissues?
Yeah, pancreas, on the pancreas, on the intestine, right? Everywhere in the abdomen.
Okay. 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 Thank you.
And that's why in case of acute pancreatitis, you mostly have the hypocalcemia also. Dystrophic calcification, right?
Okay. Yeah.
Okay, so this is the pathology behind the pancreatitis. Okay, whenever the step one asks you what is the pathology, it is always the activation of proteases ultimately. Doesn't matter how the proteases are activating, whether it is because of inflammation or without inflammation. Sometimes what happens, you have a fail-safe mechanism because some amount of proteases always become activated within the pancreas, and the fail-safe mechanism always exists to convert these activated proteases into the inactivated form again. If this mechanism is again failed, that can cause the activation of these proteases, and that can cause the pancreatitis. So multiple factors are there that can cause the activation ultimately, right? So let's discuss the causes. Mostly causes are the idiopathic. Okay. The other causes, the most common one includes the gallstones. Whenever you have a gallstones, they will block the ampulla of water, and as a result, all of the secretion from the pancreas will be start accumulating there. They will activate the enzymes because you guys already know small amount of enzymes always become activated, right? These enzymes will become activated and they will cause the pancreatitis. In case of ethanol, also you will have a spasms of the sphincter of Oddi at the ampulla of water, and because of the spasms, you will be having an obstruction, just like the gallstones, right? And because of that, the patient can also have the this episode of acute pancreatitis. Okay, and please note, whenever they want to give you a patient with alcoholism, a case of acute pancreatitis with the alcoholism, they can also mention something like the cirrhosis or the high ALT AST count. So a high ALT AST count along with the pancreatitis, okay, they can they can make you choose about the ethanol also, right? And after the after the gallstones, ethanol is the second most common cause of the acute pancreatitis. Other things includes a trauma, of course. Okay, the steroids can do that, right? The mumps virus, if you guys remember, mumps can cause the parotitis. It can cause the pancreatitis. It can cause the orchitis, as well as the meningitis, right? So mumps can cause it. Autoimmune diseases can cause it. Scorpion bite is an example. Hypercalcemia, because you know that calcium is an activator of many enzymes. Okay, and this hypercalcemia can also cause the activation of proteases that can cause the pancreatitis, right? Hypertriglyceridemia, if you guys remember from the biochemistry lectures about the dyslipidemias, we have discussed that the high level of triglycerides actually can cause the acute pancreatitis, right? And I discussed it recently also that if you're having a high level of triglycerides, then the lipases will feed on this triglyceride. They will convert them into the free fatty acids. This free fatty acids will cause an inflammation that will activate the proteases and it can cause the pancreatitis, right? And yeah, certain drugs like the sulfur drugs, NRTIs, the protease inhibitors, they can cause the acute pancreatitis also. Okay, and which NRTI most commonly can cause acute pancreatitis, if anyone remember?
Adenosine.
Yeah, the adenosine, very important. The adenosine can cause the acute pancreatitis most commonly. Okay, and the protease inhibitors, they can also cause the acute pancreatitis. Okay, so yeah, that would be the causes of the acute pancreatitis. Is that okay for everyone?
Yeah.
So we have discussed the term the pancreatitis. We have discussed the pathology behind it. We have discussed the cause of it. Now let's discuss the diagnosis. How you made a diagnosis of the acute pancreatitis? Okay. Generally, the patient present you with the epigastric pain. Remember, whenever you have any foregut pathology, you will always have a epigastric pain, right? In this case, also the patient will be presenting with the epigastric pain, and it is a very severe epigastric pain that it may also radiate to the back. Okay, it will be a severe acute epigastric pain that is often radiating to the back. Okay, then you will check the patient for the amylase level. The amylase level will be elevated along with the lipase levels. If you are having just the amylase level this elevated without any epigastric pain, that means the patient is having a inflammation of the salivary glands, right? If the patient is having a high level of amylase along with the lipases, that means the patient is having the acute pancreatitis. Okay, that means the lipases are kind of more specific to the pancreatitis than the salivary gland inflammation, right? For the imaging, you can see the edema of the pancreas. You will see the thickening of the pancreas, right? A diffuse enlargement of the pancreas will be seen on the CT imaging, right? So yeah, that would be all about the diagnosis of the pancreatitis. First is the pain, second is the enzyme level, and third is the CT image. Is that okay?
Yeah.
Now, let's discuss the complications of the acute pancreatitis. The complication first is include the pseudocyst. Now, what happens because of the inflammation, right? Yeah, one more thing. What kind of necrosis you will have in case of acute pancreatitis?
Liquefactive.
Liquefactive. Why? Because the protein digestion is there, right? And the neutrophils are also involved, and they will release the hydrolytic enzymes. Okay, that will cause a liquefated necrosis. And what will happen if I block the blood supply of the pancreas? What kind of necrosis happen then?
Coagulative necrosis.
Coagulative necrosis. Okay. In case of a blockage in the blood supply, you will always have the coagulative type of necrosis, right? In case of enzyme activation directly, you will have the liquefacted necrosis. Okay. Do not get confused. Okay. So in these cases, all of the cases that we have discussed, we are activating the protein. We're activating the proteases, right? In that case, you will have the liquefactive necrosis. Okay. And see here, the effort didn't mention about the loss of blood supply in any of the cause, right? Because in that you will have the coagulative necrosis, not the liquefatic type. Okay, so now let's discuss the complications. The first is the pseudocyst. Because of the diffuse inflammation, what's gonna happen? Because of this diffuse inflammation and the liquefatic necrosis, okay, a granulation tissue will be formed around the pancreas to limit the inflammation thing, right? And as a result, all of the inflammatory infiltrate, all of this abscess thing, right? And all of this damage will be contained within the granulation tissue, which is formed around the pancreas, right? To limit the damage, right? And this is known as the pseudocyst. Okay, it is not a true cyst because, like a true cyst, this true cyst has a real epithelium around it, right? But in case of the pseudocyst, no true epithelium exists. It's just the granulation tissue which is formed around the pancreas. Okay, and we are calling it the pseudocyst. It contains all the liquefied material from the liquefating necrosis, right? And it takes around 4 to 6 weeks to develop. Okay, and it is a most common complication, right? It generally happens in the lesser peritoneal sac. And does anyone remember the entry point for the lesser peritoneum sac?
Foramen of Winslow.
Yeah, foramen of Winslow. Okay, and generally the patient will present with a palpable abdominal mass. So a patient with a recent history of the acute pancreatitis, like 4 to 6 weeks ago or a month ago, now the patient is presenting with the emergency department with some kind of a mass in the abdomen, okay, or the abdominal distension, right? You will perform the CT of the patient, and what you will see is this kind of thing. Okay, this is the cyst thing, because this is a normal pancreas. As you can see, this is the pancreas in case of pancreatitis, and you can see the cyst formation after 4 to 6 weeks. That you will see on the CT, right? So a patient with the abdominal pain and the abdominal distension, some kind of a mass on the palpation, and this cyst on the CT. Okay, they will make you sure that the patient is having a pseudocyst. It is lined by the cannulation tissue, not by the epithelium, right? Abscess can happen because of the liquefative necrosis. Okay, hemorrhage can also happen. Okay, infections can happen, right? And the organ failure, of course, can happen. And because of the acute pancreatitis, you need to please remember that this acute pancreatitis is a very major cause of the ARDS. Very important. The patient with the pancreatitis, they can also have the ARDS. They can have the shock. Okay, they can have the renal failure also, right? They will have the hypocalcemia because of the saponification, right? So yeah, that would be all. Any doubt on that, on the complications?
No, thank you.
So we have discussed everything about the acute pancreatitis. We have discussed what the acute pancreatitis is. Okay, what's the pathology behind it, what the cause behind it, how you diagnose the condition, what are the complications, right? And in case of any alcoholic pancreatitis, what you can have first is a liver damage. The liver damage would be there, right? And second thing would be the pancreatitis also. Okay, so a liver damage along with the pancreatitis make you think about the alcoholism, right? And one more specific thing which is associated with the alcoholism is the presence of macrocytosis. Because of the vitamin B12 deficiency, because of the vitamin B9 deficiency, you can also have the macrocytosis. So step one will ask you, they will give you a patient with the history of this pancreatitis and the liver damage only. Okay, they won't tell the patient is alcoholic. You need to figure out by looking at the liver damage and the pancreatitis that the patient is having alcoholism, and they will ask you what other thing out of these options would be more specific to the cause of this pancreatitis. Okay, so that means you need to find what is specific for the alcoholism, which is not seen with other causes of the pancreatitis, like the gallstones or the trauma or other things. So that would be the macrocytosis, because you guys know that the macrocytosis will be happen because of loss of vitamin B12 and the vitamin B9, right? So yeah, that will be the other type of questions can be framed on the acute pancreatitis. And the first enzyme to be activated is the trypsinogen. It will activate to the trypsin, and finally the trypsin will activate other enzymes like the chymotrypsin, the chymotrypsin, the procarboxyl peptidase, and the prolastases. Is that okay?
Yeah.
Then comes the chronic pancreatitis. It is a chronic low-grade inflammation of the pancreas. Okay, it will be happening for like months, 2 months or 4 months or 6 months, generally more than, right? What you will have is the calcification of the pancreas. It is very important. You will have the calcification of the pancreas. You will be having the atrophy of the pancreas and the fibrosis in the pancreas in case of chronic pancreatitis. Okay, it happens because of a duct blockage. You have the pancreatic ducts, many ducts in the pancreas, and when the smaller ducts can get blocked, it will cause the inflammation at a very small area only, right? It will cause the atrophy of that area, and that's why a low grade inflammation is happening throughout the months, right? And that can cause a chronic pancreatitis, and because of damage of these ducts, the patient can also have the pancreatic insufficiency. So unlike the pancreatitis, okay, the patient won't present you with any severe pain, right? They will just present you with the insufficiency, the pancreatic insufficiency, and sometimes the pseudocysts. Okay, these are the most common type of presentation the patient will present you with. Okay, and what are the causes? The causes include the alcohol, First of all, because of the alcohol, you will be having a very protein-rich secretion from the pancreas, right? And this protein-rich secretion can also block the ducts. Okay, and because of the blockage of the duct, the patient can have the chronic pancreatitis. Second thing would be the cystic fibrosis, because you guys know in case of cystic fibrosis, you will be having a dehydration of the secretions, the body secretions, right? And as a result, these secretions will become very thick. Same case goes with the pancreas. The pancreatic secretions will become very thick. They will block the duct, right? And yeah, they can cause a chronic pancreatitis, right? Sometimes it can also be idiopathic, right? And the patient can present you with a mild epigastric pain mostly, and the pain will be present for like months, right? And when you do the lab examination, please note that the amylase and the lipase level may not be elevated. Unlike the acute pancreatitis, you can have a normal level of amylase and the lipases. Okay, the most important thing that you will see in the patient is the pancreatic insufficiency that can cause a malabsorption. The patient will get the fatty diarrhea. Okay, the patient can get the positive Sudan staining. The patient can get the loss of vitamin A, D, E, K. So vitamin complications could be there, like the bleeding complications for the vitamin K. Okay, or the pain in the bones for the vitamin D, right? Kind of blindness because of vitamin A, and the hemolysis because of vitamin E. Okay, so these are the mainly symptoms of the chronic pancreatitis. And when you do the CT of the patient, what you will see is the calcified pancreas. A calcified pancreas. As you can see, there is a diffused calcification of the pancreas is happening, and these are a very characteristic sign of the chronic pancreatitis. Okay, so atrophy, fibrosis, and the calcification of the pancreas that you will see in the chronic pancreatitis. Is that okay?
I have one question.
Yes.
Could you please explain the association between alcohol abuse and chronic pancreatitis once again?
In case of alcoholic abuse, you will be having a very high protein rich secretion from the pancreas, right? And as a result, these secretions can block the duct, just like the cystic fibrosis, right? You need to have the liquid amount more in the pancreatic secretions, right? If you have a the solute amount more than the liquid, then they can block the duct, right? And the same thing is happening with the alcohol. In case of alcohol, you will be having a too much solutes in the pancreatic secretions, and then they can block the ducts, right?
Okay, so but basically that's just a finding that the protein that there's protein rich fluid inside the pancreas.
Yeah, exactly.
Okay, thank you.
And generally, the symptoms of the chronic pancreatitis, they arises when the parenchyma is more than 90% damaged. Okay, and please note that this inflammation, this 90% damage, it is not happen acutely. Unlike in case of acute pancreatitis, this damage will be happening over the years or over the months, and that's why the presentation is very much delayed and the symptoms are very much mild. Only when the pancreas becomes less than 10%, then the overt symptoms will arise, like the diarrhea, malabsorption, and the epigastric pain. Then the patient will present you with the department with these histories, and you can diagnose the patient for the chronic pancreatitis. Okay. Are we good?
Yeah.
Okay. That's good. Just give me a second again. Yeah, so that would be all about the pancreas and all cells. Then let's discuss the pancreatic adenocarcinoma. Okay, because the pancreas is a gland, it has many glands, right? And these are lined by the columnar cells. So a cancer from these columnar cells can form the adenocarcinoma, right? And this cancer, it generally arises from the pancreatic ducts. Very important. Okay, this cancer, the pancreatic adenocarcinoma, it arises from the pancreatic ducts. And what you will see is the disorganized glandular structures on the histology. As you can see here, these are the disorganized glandular structures, as you can see, and the ANSI, look for the ANSI ratio. You have a very high nucleus from the cytoplasm, right? The nucleus size is very much increased. You will see on the histology, right? So a high NC ratio, okay, very much glandular structures, as you can see, and a disorganized of architecture of the pancreas. It will make you think about the pancreatic adenocarcinoma. Okay, it is often a metastatic this presentation, right? And the survival is very much less. after diagnosis, the patient didn't survive only for the 1 year. Okay. And the most common marker you can use for the pancreatic adenocarcinoma is the CA19-9. Okay. The CEA is also be used, but it is kind of less specific. And in what cancers you can use the CEA markers?
Hepatocellular.
Colorectal cancer.
Colorectal, yes. The colorectal, okay. Mostly the colorectal, CEA. And you also have the CA125, remember?
Yeah.
And the CA125 is for?
Ovarian cancer.
Ovarian.
Yeah.
Everything.
Okay, so remember, for the CA125, it is ovarian cancer. For the CA19-9, it is the pancreatic adenocarcinoma. For the CEA markers, it is the colorectal carcinoma. Okay, so the risk factors, the tobacco smoking, very important. The smoking is the most important risk factor for the pancreatic adenocarcinoma, or you can say a single most important risk factor, right? The second includes a chronic pancreatitis, because whenever you are having any chronic inflammation, you can have an increased risk of cancers, right? Diabetes is also an important cause, right? Age, which is more than 50 years, right? And the Jewish population or the African American males, these are the they have a very high rate of these cancers than other populations, right? Very important. So descent is very important. Age is important. Okay, the history of tobacco smoking is the most important one. Okay, the chronic pancreatitis is important, and diabetes is important. These are the risk factors for the pancreatic adenocarcinoma. Now let's discuss the presentations. So just like any other foregut pathology, the patient presented with abdominal pain. Okay, and this pain will radiate to the back again. Okay, the patient, just like any other cancer, will have a weight loss. They will have anorexia. They will have some nausea, and because it is adenocarcinoma, the patient will be having a very hypercoagulable state. Okay, so the patient can have an episode of deep vein thrombosis or multiple episodes of deep vein thrombosis, and that even can occur because of the pulmonary embolism, right? The patient will have a migratory thrombophlebitis, which is a Trossio syndrome. Okay, the same scientist who developed the hypocalcemia, the signs and symptoms of hypocalcemia, the Trossio sign. Okay, this scientist again developed the migratory thrombophlebitis. Okay, what happens? You will having a superficial vein thrombosis, right? And because of the superficial vein thrombosis, you will be having a very linear swelling on the hand or on the arm, or on the legs or anywhere in the body. Okay, you will be having a very linear swelling with a lot of pain. Okay, and initially we will be having a swelling in one hand, then the swelling will be disappeared and will and will present on the other hand, right? So it is a migratory type of thrombophlebitis. Pain will be there, swelling would be there, redness would be there, and warmth would be there, right? And because these cancer, if it is a head of if it is a cancer of head of pancreas, then it can also block the ampulla of Vater, which means the patient can also have the obstructive jaundice. Okay, and it would be a the painless palpable gallbladder. Okay, generally when you have any kind of obstruction or any kind of a thickening in the gallbladder, this condition is generally painful, like the Murphy sign, if you remember, right? But in case of this the pancreatic adenocarcinoma, you will be having a palpable gallbladder. Okay, but it is painless, not a painful. Okay, this is an important thing. So whenever you have a painless obstructive jaundice, okay, there will be a high chance of developing the pancreatic adenocarcinoma. Okay, you'll be having a non-tender gallbladder, which is the Courvoisier sign. Okay, and yeah, that's all about the pancreatic adenocarcinoma. Now let's discuss the treatment. Treatment is the Whipple's procedure. Okay, in which you do the pancreatoduodenectomy. You will remove the pancreatic head, tail. You will remove the part of duodenum also. So this is a pancreatoduodenectomy that you will do for the Whipple's procedure. Okay, you can also give the patient chemotherapy, of course, and the radiotherapy. Okay, and as you can see on the CT examination of this patient, as you can see, this is a tumor growth in the pancreas. Okay, very important thing. And yeah, that would be all. So any doubt about the pancreatic adenocarcinoma?
No, thank you.
Okay, so We will take again a short break of 5 minutes, only 5 to 7 minutes. Okay. And then we start the pharmacology. Okay.
Okay.
Okay. So GI pharmacology. First, you need to know about the acid suppression therapies. What are the drugs that suppress the acid production? And all of these drugs are useful for the acidity thing. Okay. For the GERD. Okay. So you guys already know that the acid production is totally dependent upon the parietal cells. Okay. And the parietal cells, they have this ATPase pump. Okay. Which will secrete the hydrogen ion into the lumen. Okay. And will take up the potassium ion in the gastric parietal cell. Right. Second type of pump you will have is a chlorine bicarbonate pump. And you guys already know that whenever you have a high chloride level, you will always have a low bicarbonate level. And when you have a high bicarbonate level, you will always have a low chloride level, right? Because they're negative charge and they will always kind of, opposes each other, right? So you have these pumps, okay? And the function of this pump is to influx in the chlorine, okay? And to efflux out the hydrogen, this bicarbonate, okay? And they will secrete the bicarbonate in the blood, okay? And from the blood, they will take the chlorine, okay? So you have the hydrogen, you have the chlorine will come in, and from the and from these channels, from the chloride channels, it will be efflux out of the gastric parietal cells within the GI lumen, right? And there the H plus will combine to the chlorine to form the HCl, right? That's how the production of this HCl happens, right? The activity of this pump, it depends upon the cyclic AMP levels and the IP3 levels, IP3 DAG, which means the GQ. So both the GS as well as the GQ, they will activate the this pump, the ATPase pump, right? So you have certain therapies which will inhibit either the cyclic AMP or the IP3 DAG to ultimately inhibit this production of acid. First of all, you will first let's discuss how the production occurs. So you will have the vagus nerve, and if you guys remember, the vagus nerve will release two things. One is the acetylcholine, and second is the gastrin-releasing peptide. The acetylcholine will directly activate the muscarinic receptors, the M3 receptors. Okay, and these M3 receptors will go through the GQ and they will activate the ATPase pump. Similarly, you will have the gastrin, and the gastrin function first is to directly stimulate the CCK receptors, right? And the second thing is to act on the enterochromaffin cells to release the histamine, right? So the gastrin is released from the G cells. Okay, it will be stimulating the CCK receptors, the CCK B type receptors, which will activate the GQ again. Okay, and by the IP3 DAG, it will activate the this ATPase, right? Third thing, you will have the histamine, and in the histamine, you will have the H2 receptors. Remember, the H1 receptors are for the GQ, and the H2 receptors are for the GS, right? So H2 type, which is GS type receptors, are found in the GI tract, and they will activate the cyclic AMP, right? And by activating the cyclic AMP, they will activate the ATPase pump to form more acid. Okay, so matostatins and the prostaglandins, okay, they inhibit the cyclic AMP, very important. So matostatins and prostaglandins, they inhibit the cyclic AMP via GI, right? And as a result, they will inhibit the acid production. Okay, now let's discuss the drug therapies. So first is the anti-muscarinic drugs like the atropine. Okay, they will inhibit the muscarinic receptors and as a result inhibit the acid production. Okay, then you have other drugs like the histamine blockers. Okay, and the name of the histamine blockers includes cimetidine, ranitidine, famotidine, and nizatidine. So they all have a name dine in it. Okay, DINE at the end of the name. Okay, cimetidine, ranitidine. These are all the histamine H2 blockers. Okay, then you also have the main one are the proton pump inhibitors. Okay, they directly inhibit the ATPase, and as a result, even if you have the acetylcholine, even if you have the gastrin or the histamine, okay, all of these three agents, they cannot cause the acid release if you have the proton pump inhibitors, and this is very important. Okay, because in case of histamine blockers, the gastrin and the acetylcholine, they still can cause the acid production. Okay, but if you give the patient proton pump inhibitors, doesn't matter if you have the high level of all these three substrates, okay, they cannot cause the acid release, right? So these are therapies which inhibit the acid production. Then you also have the antacids, okay, which will combine with the with this H plus ions to form the anionic state. right? They will make the environment very much basic so that they will release, they will receive the H plus, okay, and they will cause the a high pH, right? Where second, you have the the bismuth and the sucralfate. They will form a layer over the ulcer, right, to protect them from the acid. Okay, then you have the mesoprostol. Okay, and the function of the mesoprostol is to inhibit or activate the prostaglandins.
Activate.
Activate the prostaglandins. Okay, and the mesoprostol you generally used for the NSAID induced ulcer, because you guys know whenever I give the patient NSAID, it will inhibit the prostaglandins, right, by inhibiting the COX. So you can have ulcers in the NSAID therapy. Similarly, you can also have the ulcers in the glucocorticoid therapy, because the glucocorticoid, they also inhibit the COX enzyme, right? So for these type of ulcers, I generally use the mesoprostol. Okay, and whenever you eat food, whenever you have a high acid production, as you can see, the bicarbonate will be releasing in the blood. So whenever you have a meals or a vomiting, or or anyway, if you're having a high acid production, you will always have a high pH in the blood. Okay, so acid in the stomach. Okay, whenever you have an acid in the stomach, you will have the high pH in the blood, and this is known as the alkaline tide, which has happened because of the gastric acid secretion. Is that okay?
Yeah.
So whenever step one, give you a certain scenario in which the patient is having this alkaline pH in the blood, okay, and and he's eating food, so they can ask you, uh, which stage of the acid production is it, right? Remember, you have three stages. One is the cephalic phase, second is the gastric phase, and third is the intestinal phase. So in the intestinal phase, you will be actually inhibiting the acid production, right? Which means you will decrease the pH of the blood, right? But in case of the cephalic phase and the gastric phase, you will be having a high pH. Okay, so by giving the blood pH, they can ask you which phase of the acid production it could be. So you need to remember. Is that okay so far?
Yeah.
Okay. Um, then let's discuss about these drugs, the individual ones. Okay. So first are the histamine H2 blockers. Okay, these are the cimetidine, ranitidine, famotidine, and nizatidine. Everyone has the name dine in it at the end, right? They block the H2 receptors, so they decrease the H plus production by the parietal cells. They can be useful for the peptic ulcer disease, for the gastritis, and the mild esophageal reflux disease, which means the GERD. Okay, you generally uses the proton pump therapy for the GERD only, right? But for the milder form of GERD, you can even use the histamine blockers. Side effects are very important. Especially the cimetidine, it is an inhibitor of cytochrome P450, as well as these are the anti-androgenic drug. Very important. Okay, these are the anti-androgenic drug as well as a cytochrome P450 inhibitor. So they can cause the increase in the prolactin release. They can cause the gynecomastia. They can decrease the libido, and they can cause the impotency. Okay, and that's why you can also use these drugs whenever you have a high androgen productions. Okay, so they can be useful as the anti-androgenic therapy, the cimetidine drug. Very important. Okay, and these drugs can also cross the blood-brain barrier. Very important. So by crossing the blood-brain barrier, they can cause the confusions, dizziness, headache. Okay, why headache is occurring?
Because of alkalosis.
Okay, and yeah. Okay, so both the cimetidine and the ranitidine, they will decrease the renal excretion of the. This is very important. Okay, both the cimetidine as well as the ranitidine. Okay, they will cause a decrease in the renal excretion of the creatinine. So whenever you give these agents to the patient, they can have a high level of creatinine, which will make it look like the patient is having the kidney dysfunction, right? So these drugs can also do the kidney dysfunction, a very important thing. Okay, so 3-4 side effects. First is the cytochrome P450 levels. Okay, so remember which drugs you actually need to control the level for cytochrome P450. Which 2-3 drugs you need to monitor for the cytochrome P450 levels? whose levels are ultimately being regulated by these activators or the inhibitors?
Phenobarbital.
Phenobarbitals are the activators, but you, other
Are you asking about substrate for P450 systems?
I'm asking about these drugs, the activators or inhibitors, they control the level of other drugs, right? We have a list of 4 or 5 drugs which are being controlled by this cytochrome P450 levels, which are the important ones. And does anyone remember the name? Like the theophylline and the warfarin, remember? The OCP
Yeah.
therapies. So these drugs are ultimately being controlled by the activation or the inhibition of these drugs, right? Remember these names, very important. And yeah, so you can be use these drugs for the PCOS also as the anti-androgenic therapy, because you know that in case of PCOS, you will be having a very high level of androgens also, right? And they can cause the hirsutism, right? So cimetidine is very useful for the treatment of such things. Okay, for the PCOS, you can be use these agents. Then comes the proton pump inhibitors, and they inhibit the acid production by inhibiting the ATPase pump in the parietal cells. As a result, it doesn't matter if you have a histamine, if you have a gastrin, or if you have a ACH, you just cannot produce the acids. Okay, they irreversibly inhibit the hydrogen potassium ATPase in the stomach parietal cells. So what are the uses? The uses will be the peptic ulcer disease, gastritis, esophageal reflux disease, Zolliger ulcer syndrome. Okay, and there are also the component therapy for the H. pylori, right? Because in case of H. pylori, you will be having the ulcers, right? So first thing, you will decrease the acid production in case of ulcers, and the second thing, you will treat the cause of the ulcer, which is the H. pylori, by giving the antibiotics, right? And you can use the proton pump therapy also for the stress ulcers. Okay, and why the stress ulcers are occurring? Why in the stress you will be having the ulcers?
Decreased blood flow.
Okay, or
Excess stimulation of vagus nerve.
okay, and stress means psychological stress also, right? Not just not the physical stress. In case of psychological stress also, you will be having the ulcers. Like if you're having some kind of a tension, some patients always complain of the abdominal pain, right? About the acidity thing. So why in case of stress you're having the ulcers?
Cortisol,
Yeah,
glucocorticoids.
exactly. Glucocorticoid therapy, right? Whenever you have a stress, you will be having a high level of glucocorticoids, the cortisol, and that can cause ulcers, right? So in all these agents, whenever you want to decrease the acid level, like in case of reflux or gastritis or ZD syndrome, you will be using the proton pump therapies. Now let's discuss the side effects. First thing, if you inhibit the acid production by these proton pump inhibitors, that means you will be having you will be giving this negative feedback to the gastrin, right? And as a result, the gastrin will stimulate the proliferation of the parietal cells. Okay, what you can have is um, the wall thickening of the stomach. First, you will have a high gastric rage, right? And if you immediately stop the PPI therapy, right? Sometimes if you ran out of the medications, or or you just forget to take the medication somehow, right? In that case, you will be having a very high release of the acid. A reflex release in the acid will be there, right? And that can cause the again symptoms of gastritis. So if you're on a patient who is on the PPI therapy and you abruptly stop these drugs, then you can have a reflex acid production, a very large amount of acid production because of the hyperplasia of the parietal cells and the very high gastrin levels, right? Second thing, they increase the risk of Clostridium difficile infection. We have discussed that already. If you take the PPI therapy, you can have a pseudomembranous colitis, and that's why these drugs are contraindicated in the old age. Okay, we have discussed that already in the pharmacology section, digital pharmacology. We have discussed how the proton pump inhibitors are contraindicated for the old age because they can cause the pseudomembranous colitis. They can also cause the pneumonia. Okay, they have due to increase in the gastric pH, because you know that stomach pH is very much useful for the for the for the destruction of these bacteria. So if you have a high pH, they can cause the increased risk of infections. Okay, they can also increase the risk of acute interstitial nephritis And what type of hypersensitivity reaction is this?
Type 3.
Yes, type 3 hypersensitivity reaction, right? They also inhibit the vitamin B12 absorption. Why? Because the parietal cells are also responsible for the synthesis of intrinsic factors, and you require the acidic pH to release the binders for the vitamin B12. Okay, when you take the vitamin B12, it will be binded with the animal binder, right? And this animal binder must be removed so that the R binder could be attached, and that is done by the acidic pH, right? So if you inhibit the acid, then you will have a vitamin B12 malabsorption also. Okay, you will also decrease the absorption of magnesium and the calcium. Okay, and that can lead to the increased risk of fracture in the elderly, and that is the other reason why you don't want to give proton pump inhibitors to the old age patients. Okay, so step one can also present you a scenario over that thing. It would be a patient who is having a history of this GERD or a gastritis, and now she is having a fracture at a very early age. So they will ask you the cause of the fracture. This is a proton pump inhibitors. Okay, and one more thing that you must remember, that the lipases, okay, they get activated in the acidic medium, right? Very important. Lipases, they get inactivated in the acidic medium. So whenever you give the patient proton pump inhibitor therapy, you can also have the uh, inactivation of the lipases, right? So you will have a fat malabsorption, right? Sorry,
It's
just give me a
reverse.
second.
I think it's reverse.
Just give me a second. Yeah. So the lipases get inactivated in the acidic medium. So if you give the patient proton pump inhibitors, okay, then you're inhibiting the acidic medium, right? And as a result, the lipases will become too much activated, so they will cause the increased absorption of the fat. Okay.
Okay.
Okay, so step one can also ask you this fact, right? And so they will ask you about the PPA therapy. They will give you a scenario where the patient is using the PPA therapy, and they will ask you, what nutrient absorption will be increased in your body. They will give you a fat, protein, and other options. So it would be the fat absorption which is increased in case of PPI therapy, right? And you will have a decreased absorption of the electrolytes and the vitamin B12. Okay, and the amylase and proteases, they also require the acidic medium for the activation. In case of in case of PPI therapy, their activation is reduced, so you will get the decreased absorption of the proteins also, right? So a decreased absorption in proteins, nutrients, vitamins, and an increased absorption in the fat that you will see in the proton pump inhibitors therapy. Any doubt on that?
I have a
When headache.
You were talking about a hypersensitivity reaction. Can you explain that?
See, this acute interstitial nephritis is a type 3 hypersensitivity reaction that occurs whenever you start taking a new drug like the penicillins or the sulfonamides or the proton pumps or the this NSAIDs or the diuretics. If you guys remember from the renal sections, okay, then because of these drugs, okay, a type 3 hypersensitivity reaction occur. Formation of immune complexes happen, which will deposit in the interstitium of the kidney, okay, and the interstitium is between the nephrons, right? And that can cause the acute interstitial nephritis.
Was this the Hapten type drugs?
Yeah, exactly.
Awesome, thank you.
Okay, any more doubt?
Methylene and headache. How is that related?
Headache in case of
The methylene.
see, these drugs are actually crossing the blood-brain barrier and entering in your this head in the brain, right? And they can interfere with the receptors present in the blood vessels. So that's how they can cause headache, right? It's just nothing but a simple thing. Just they can cross the blood-brain barrier, they can enter the brain, and they can interact with the histamine receptors there, so they can cause a headache there. Nothing much more complicated about that. Okay, not a specific cause for the headache. It's just interfering with the brain, and they can cause a headache there. That's why. It just they invade the it just they causes a vasoconstriction at some places. Okay, and the blood supply will be decreased there. So at other areas, the blood supply will be increased, the vasodilation will occur, and that can cause the headache, right?
Okay.
Okay. Yeah. Any more doubt?
Is there any specific reason of uh, reduced absorption of magnesium and calcium?
It's just the acidic medium is required for their absorption. So if you inhibit the acidic medium, then you will have a low absorption. Right? And one more drugs, if you guys remember, the azoles, I think it was, right? Azoles, or just give me a second, or the nystatin. It was azoles, right, which required the acidic medium for the absorption. Remember the microbiology section, we have discussed about that. Sorry about that. Just give me a second. Yeah, it was the azoles, and they also required the acidic medium for the absorption. So if you give the patient these therapy, the proton pump inhibitors or the antacids, right? So they will be increasing the pH in the stomach, right? And they will interfere with the absorption of these drugs. So they can cause the treatment failure also in case of fungus treatment. Is that okay?
Yeah, okay.
So yeah, that is this thing, please remember. Okay, the calcium malabsorption, the magnesium malabsorption, the difficult infection, pneumonia, vitamin B12, increased fat, low protein, and a decreased absorption of the azoles. All of these things for the proton pump inhibitors. So their side effects are kind of more important than the clinical use. Okay. Okay, now comes the antacids. Okay, antacids, they will be also increasing the gastric pH. Okay, so they can affect the absorption again. Okay, and the bioavailability of the drugs and the urinary excretion of the drugs by altering the gastric pH and the urinary pH also, right? And they all can cause the hypokalemia. This is an important thing. Okay, and the antacids include the aluminum hydroxide, calcium carbonate, and the magnesium hydroxide. So two hydroxides and one carbonate. Aluminum, magnesium hydroxide, and the calcium carbonate, these are the antacids. Okay. For the side effects, they all can decrease the absorption of other ions, okay, or other drugs. We will discuss that soon. Don't worry. The bioavailability of the drugs, the excretion of other drugs by interfering with the gastric pH and the urinary pH, right? So for the aluminum hydroxide, the side effects include the constipation, very important. Okay, hypophosphatemia. Okay, osteodystrophy could be happen, and the paroxysmal muscle weakness. And the most you can forget all of these, but just remember that the aluminum hydroxide can cause the constipation and the osteodystrophy. These two are very important for the aluminum hydroxide. For the magnesium, it can cause the diarrhea. Okay, and because the aluminum is causing the constipation and magnesium causing the diarrhea, you generally combine these two drugs to have a neutral effect. Okay, so step one can ask you this thing, why you want to combine the aluminum hydroxide and the magnesium hydroxide to a patient. It is to reduce the side effects, right? Because the constipation and diarrhea, they will neutralize each other. The patient's side effects will be reduced. Okay. For the calcium carbonate, you can have a hypercalcemia because of milk alkali syndrome. Okay, because of the whenever you take the calcium in the diet, like the milk, okay, this calcium carbonate will causes the increased absorption. Okay, it will interact with that and it will cause the hypercalcemia. And because of the hypercalcemia, okay, and the patient can have an inhibition of the PTH. The patient can have a low vitamin D3 levels. Okay, and yeah, and the inactivated vitamin D3 will be increased, which is 24. See, the activated form of the vitamin D3 is the 125 hydroxy vitamin D3, and the inactivated form of vitamin D3 is 24-25 hydroxy vitamin D3. Okay. So Stefan can also ask you these lab values. What will happen when you give the patient calcium carbonate along with the milk? The patient will having a hypercalcemia because of increased absorption, because you are already having a calcium carbonate therapy. Okay. Second thing, because of the high calcium level, the patient can have an inhibition of the PTH, inhibition of the vitamin D3, and the more levels of the inactivated vitamin D3. Right. This is the milk alkali syndrome. Okay, it is because of the alkalosis and the renal dysfunction. Okay, so yeah, that's usually the thing. And doubt, yeah,
Get the increased pH because of neutralization of hydrogen ions.
yeah, exactly. They will neutralize the hydrogen ion because the calcium carbonate is a base. right? And whenever you give the base, it will raise the pH, it will accept the hydrogen ions, right? And it will cause the neutralization effect.
Okay. And why do we get hypokalemia?
We're getting hypercalcemia.
No. In general, in antacids, it's written
They will
all
interfere.
can
See,
cause.
all drugs can interfere with the absorption of certain ions, right?
Yeah.
That's why. And second thing is, they're causing the metabolic alkalosis also. So it is somewhat linked to the excretion of these ions also, right? So excretion of these ions and a decreased absorption,
Okay.
all combined can cause the hyperkalemia, right?
Yeah. Thank you.
Okay. Just give me a second again. And yeah, you can think it like that also. See, in case whenever you have a high aldosterone levels, you will be having a metabolic alkalosis, right? And that will cause the excretion of the potassium, right?
Yeah.
So you can relate, whenever you have a metabolic alkalosis, you will be having an excretion of the potassium from the kidneys, right? And plus you will be also having an intracellular shift of the potassium because of this
Shift
because
of
of
hydrogen and
alkalosis.
potassium.
Yeah,
Yeah.
exactly. So because of the shift of this potassium inside the cells, and because of the increased excretion and decreased absorption, you will be ultimately having the hyperkalemia. Okay.
Yeah. Okay.
And must remember three drugs for the antacids. One is the tetracyclines, second is the fluoroquinolones, and third is the levothyroxine. These drugs can chelate these drugs. Okay, these antacids can chelate these drugs, and as a result, they will decrease the absorption of these drugs and can cause a therapeutic failure. So whenever you encounter a patient who is having a history of some kind of an infection, taking the tetracyclines, right, and at the same time he's also taking the iron supplements, or the anti-acid supplements for the acidity, for say, okay, and the patient suddenly having an episode of again the infection, okay, or the patient is having a treatment failure. All right, so step one will ask you why the patient is having a reinfection with this bacteria or the therapeutic failure. It is because of decreased absorption of the drug, right? Similar thing goes for the fluoroquinolones. The patient will be having an episode of pneumonia, which you will give the patient fluoroquinolones, or the UTI maybe, right? And again, the patient will started taking the iron supplements or maybe the antacids, and now the patient is again having an episode of UTI or the pneumonia. So they will ask you why this thing is happening. It is because of decreased absorption. Same with the levothyroxine, which is a T4. Okay, you will get the hypothyroidism again because of treatment failure. Why? Because of the chelation. Is that okay? Remember these three drugs only. Okay, and other drugs that you can remember is the ketoconazole or other azoles, right? Because they also require the acidic medium for the absorption, right?
Yeah.
So mainly these drugs for the chelation and the azoles for the decreased absorption because of loss of acidic pH. So these things are interfere with the antacids. Then comes the bismuth or the sucralfate. They basically makes a protective layer over the ulcer, okay, to prevent them from the from the action of the acid, right? And one of the bad thing about the sucralfate is that it requires the acidic environment. Although it is preventing your ulcers from happening, but it requires the acidic medium first in order to cause a beneficial effect, right? And yeah, that would be it. And that's why the sucralfate is not given with the PPIs and the histamine blockers, because they raise the gastric pH, and the sucralfate won't work. You generally give the bismuth along with the PPIs and the histamine blockers. Okay, and the use would be in the cortical therapy for the H. pylori. Okay, very important. And the bismuth can also be useful for the traveler's diarrhea. Okay, it will promote the ulcer healing. Okay, then comes the misoprostol. The only use is the NSAID-induced peptic ulcers. Okay, and you need to be very careful by giving while giving giving this drug because it can cause the cervical thickening. It can induce the labor also, right? Because the prostaglandins, they are smooth muscle contractile agents, right? So they will cause the contraction in the uterus. So you cannot give this misoprostol in case of a pregnant female because it can cause the miscarriage. Okay, very important to note. Okay, and yeah, that's all about it. It's a prostaglandin even analog. Okay, it will increase the mucosal barrier by decreasing the acid production. So adverse effects include the diarrhea. It is contraindicated in the woman of the childbearing age because of the abortifacient activity. Okay, and you generally give the misoprostol along with the mifepristone for the abortion. It is very important. You generally give the misoprostol with the mifepristone, and the mifepristone is the analog or the anti-drug for the progesterone.
Antagonist.
Okay, so mifepristone is the anti-prostagens drug. Okay, so we give the anti-progesterone as well as the analog of the prostaglandin to induce the contraction in the uterus so that the abortion can also happen. Very important. Any doubts so far?
Could you please explain why mifepristone is given along with it?
Mifepristone is given along with the misoprostol. See, misoprostols, because it is a prostaglandin analog, and the prostaglandins, they will cause the smooth muscle contraction in the uterus. Okay, and
Yeah.
the mifepristone, because it is an inhibitor of the progesterone, and the function of the progesterone is to cause a relaxation, right, in the uterus. Okay, so you're actually inhibiting the relaxation and promoting the contraction in the uterus, and that can cause the abortion.
Okay.
So that's why you combine the misoprostol along with the mifepristone for the abortion, right? And that's why
Okay.
this misoprostol won't be given in the pregnancy. It can cause abortion.
Okay, got it. Thank you.
Then there comes the octreotide, which is a somatostatin analog. We have discussed that many times. You will use that for the acute varicose bleeding, for the acromegaly, for the VIPoma, for the carcinoid tumors. Okay, and because the somatostatin inhibit the CCK hormone also, right? If you give the patient octreotide therapy, then you can have a gallbladder stasis, and for that the patient can have a cholelithiasis. Is that okay?
Yeah.
You will also use the octreotide for the management of portal hypertension, right? Because in case of portal hypertension, you need to inhibit the glucagon or the epinephrine that can cause the vasodilation, right? So by inhibiting these things, you can have a vasoconstriction that could prevent this hypertension, right? Now comes the drug, the sulfadiazine or the sulfasalazine. Okay, these are the 5-amino salicylic acid. Okay, they belong to a category antibacterial drug, the sulfur drugs. Remember the sulfonamides.
Yeah.
Okay, these sulfonamides, this sulfasalazine is actually a sulfonamide drug. Okay, which could be useful in case of ulcerative colitis and the Crohn's disease. Okay, it has a major action only on the colon because it is activated by the colonic bacteria. Okay, that's why you can use this drug for the treatment of ulcerative colitis as well as the colonic component of the Crohn's disease, because you know that the Crohn's disease can happen from your esophagus to the colon, right? So whenever the Crohn's disease is in the colon only, then you can use the sulfasalazine. And by what symptom you can know that the patient is having a Crohn's disease in the colon? Not by the labs, but by the symptom.
Bloody diarrhea in
Bloody
ulcerative
diarrhea.
colitis.
Yeah, exactly. Whenever you have a bloody diarrhea, that means the patient is having a colitis thing, which means could be the ulcerative colitis or the colitis in the Crohn's disease. Okay, all they can cause the sulfonamide toxicity. Of course, they can cause oligospermia, they can cause a malaise, nausea, glucose 6-phosphate dehydrogenation, they can cause a hemolysis, they can cause a connectors and other side effects of the sulfonamides. Okay. Then comes the loperamide, which is the mu receptor agonist. And because it is a mu receptor agonist, it can cause the constipation. The special thing about this drug is that it cannot cross the blood-brain barrier. That means it has no CNS side effects. Okay, you will give this drug to a patient having the diarrhea, but before giving the patient loperamide, you need to make sure that the patient is not having any infectious kind of diarrhea, right? Because in case of a toxin-induced diarrhea or in case of any infectious diarrhea, okay, you need to eliminate the toxins from the body, right? And the toxins can be eliminated by the diarrhea only, right? And that's why you won't give the patient loperamide in the toxin-induced diarrhea. You always need to make sure that the patient is having some kind of a malabsorptive diarrhea or a diarrhea because of high electrolytes or something like that, okay? Or any structural cause like the, like this lactose intolerance maybe sometimes, or the this irritable bowel syndrome. Okay, so only in these kind of diarrheas you can give the patient loperamide, not in case of infectious diarrhea or the toxin induced diarrhea, because in that case you need the toxins to be eliminated from the body. Okay, any doubt?
No, thank you.
Then comes the anti-emetic agent, which is the ondansetron. Okay, it is a serotonin antagonist. It will inhibit the vagal stimulation. Okay, so work as a powerful anti-emetic. Okay, you mainly use this drug for the chemotherapy or the post-operative vomiting. Okay, so whenever you encounter a case of a chemotherapy or the post-operative vomiting, you will always choose the ondansetron. Okay, although metoclopramide can also be used, but we don't use metoclopramide that much. Okay, mainly for the diabetic gastroparesis we use the metoclopramide, but for the chemotherapy and the post-operative emesis, okay, you use the ondansetron. Step one will ask you this. They will give you a patient, okay, with the chemotherapy, and they will ask you about the vomiting. Okay, which drug should be given? They will give you the metoclopramide in the answer. They will give you the ondansetron in the answer. So please note, you will choose the ondansetron over the metoclopramide for the post-operative vomiting and the chemotherapy-induced vomiting. Okay. Side effects include the constipation, headache, right, and the QT interval prolongation and the serotonin syndrome. If you guys remember, we have discussed about the A, B, C, D, E mnemonic for the QT prolongation. A for the antiarrhythmic agents like the class 3 and the class 1 agent. B for the antibacterial agents, right? Like the macrolides and the fluoroquinolones also. For the C, we discuss the antipsychotics, right? And what antipsychotics?
Haloperidol,
Exactly. For the D, we discuss the
antidepressants,
antidepressant, and these are
tricyclics.
tricyclic antidepressants, right? For the E, the anti-emetics, and it includes the ondansetron, right?
Yeah.
Okay, and that's all about it. So now comes the metoclopramide. Okay, it is a D2 receptor antagonist, and because it is a D2 receptor antagonist, okay, first thing, it will increase the resting tone, it will increase the contractility. Okay, it will cause the uh, lower increase in the lower esophageal sphincter tone. Okay, and the mobility will be increased. Okay, so it promote the gastric emptying. Okay, it promote the diarrhea and it will inhibit the vomiting. Okay, and does anyone remember the D2 receptors?
In the brain.
Yeah, in the brain, of course, but does the GQ or the S or GI, what kind of G protein coupled receptor D2 are?
GI.
Yeah, GI type. Okay, very important. Just give me a second. Let me confirm it. I'm forgetting actually. Yeah, D2 receptors are GI type. Okay, so they basically inhibit the relaxation. So they increase the tone. Okay, they increase the contractility, they increase the motility. So where you can use these drugs, you will use these drugs for the diabetic or the post-operative gastroparesis. Mainly for the diabetic gastroparesis, only for the post-operative one, you will, you will use the diabetic and the post-operative gastroparesis. For the antiemetic, you will use them in the migraine-induced nausea only. Okay, for the post-operative nausea and for the chemotherapy-induced nausea, you will use the ondansetron. Okay, please remember, for the gastroparesis, metoclopramide. For the nausea vomiting, you will use the ondansetron. Okay, if the patient is having a persistent GERD, you can also give the patient metoclopramide because it increases the lower esophageal sphincter tone, right? Side effects, because they're inhibiting the D2 receptors, they will interfere with the basal ganglia and they can cause the increase in the EPS symptoms, just like the Parkinsonism or the tardive dyskinesia or the acute dystonia, or the restlessness, right? To prevent these conditions, you need to give these drugs along with the diphenhydramine. Okay, you generally give these drugs with the diphenhydramine to counter the EPS symptoms. Very important. So step 1 will ask you about the metoclopramide. Okay, they will ask you that that this drug is being combined with the diphenhydramine for what cause? So it is to inhibit the EPS symptoms. Very important. Okay, and that's all about it. And it is contraindicated in the patients with the small bowel obstruction, because in case of small bowel obstruction, if you increase the tone and you increase the contractility, then it will cause a further more kind of pain in the patient, right? Because of the spasm things. So you won't use these drugs for the small bowel obstruction, right? Yeah, that would be all about the metoclopramide. Any doubt?
I have one question from audience sector.
Yes.
Even though the mechanism is serotonin antagonism, but the
Yes.
side effects, one of the side effects says it causes serotonin syndrome.
Yes.
So how does that happen?
Uh, I think it's kind of complicated. I really don't know about the mechanism behind it.
Okay, no problem.
You should give
Yeah.
other
Thank you.
drugs, anti-anxiety drugs like the Salas and all.
Someone is saying something, I think. Any doubt? Or maybe a statement?
Along with the Zofan, if you give other anti-anxiety medication like Zoloft, like other serotonin drugs, then you can get serotonin syndrome.
You can speak loudly.
It's okay.
Oh, okay. Okay, so that was all about the metoclopramide. Then comes the orlistat. Okay, we have discussed that already in the in the endocrine section, that it is a pancreatic lipase inhibitor and the gastric lipase also. So basically, it inhibits the pancreatic lipase so that the fat malabsorption occur. Okay, so it will be useful for the weight loss. And because of fat malabsorption is occurring, it will also cause the steatoria and the loss of fat soluble vitamin absorption, vitamin A, D, E, K. Okay, so that would be all about the orlistat. We have discussed that already in the endocrine section previously, right? And one important drug is the diphenhydramine. Okay, it is also a mu agonist, just like the loperamide. Okay, so it will cause the constipation. It is most useful for the diarrhea, but it can cross the blood-brain barrier, in a very kind of mild capacity to cross the blood-brain barrier. So basically, if you take these drugs in a controlled amount, okay, then no CNS symptoms will offer. Okay, but if you take these drugs in a very high amount, okay, then in that case, the patient can have a symptoms of the brain like the euphoria and other opioid symptoms, right? To promote this condition, okay, so to discourage this thing, okay, they're generally given with the atropine, so that if the patient try to abuse these drugs, okay, then they will have an anti-muscarinic side effects. Okay, and these side effects include the loss of sweating, okay, this the high temperature, okay, the loss of sweating, the loss of saliva, dryness completely, constipation, right, and all other things. So very important, you generally give the diphenhydramine for the along with the atropine to decrease the abuse of these drugs, okay, because at higher doses, these drugs can promote the euphoria also. Is that okay?
Yeah.
Do we use
Well,
it apart from IBS?
yeah, just like the loperamide, okay, the conditions where you can use a loperamide, the same condition you can use this drug also, diphenhydramine, okay. Like in case of the lactose intolerance, you can use this agent, okay. So in any conditions where you're having a diarrhea which is non-infectious or non-inflammatory type, right, in that case you can use a diphenhydramine. Okay.
So it crosses the blood-brain barrier. That is why it is causing dependence, right?
Yeah, it can cause a dependence, it can cause a
Diphenhydramine.
euphoria and other CNS symptoms, and that's why you will give these agents with the atropine also.
Atropine.
So yeah,
Okay.
very
Thank you.
important. Someone will ask you this fact, why it is given with the atropine, because it can cross a blood-brain barrier, right? And Istanbul can also ask you why the metoclopramide is given with the diphenhydramine. It is to promote, it is to prevent the EPS. Okay, so any doubts so far on this page?
Could you please explain why atropine is given?
To promote the abuse, if you take these drugs in a high amount, then you know that it can cause a euphoria, dependence, and other things for the brain, right? But
Yeah.
if you give them with the atropine, if the patient takes them in a high amount, then atropine will also work. It will cause the anti-muscarinic symptoms like the high fever, abdominal pain, okay, and the constipation, and this loss of sweating, loss of saliva, right?
Yeah.
That's why.
Okay, so there's atropine is having a completely different mechanism of action over here.
Yeah, exactly. It is just to stop the abuse, okay, because the symptoms
Right.
will occur and the patient will be having these problems if they take them in a high amount.
Okay, yeah, I got it. Thank you.
Okay, then comes the laxatives. Okay, and laxatives are mainly indicated for the constipation because they promote the bowel emptying, right? But certain laxatives can also be given in case of diarrhea. We will discuss that. Okay, and you can also use these laxatives for the opioid requiring bowel regimen. Okay, because if you give the patient opioid therapy for the pain relief, right, then you know that the opioids can cause the constipation. Okay, and you cannot just given other drugs other than these laxatives because they can cause further most side effects, right? So laxatives are mainly given for the opioid induced this constipation, right, and other causes of constipation. The first one is some bulk forming laxatives like the psyllium. Okay, they are just the fiber supplements which cannot be absorbed in your GI tract, and as a result they will increase the kind of osmolarity of the GI tract, right? So they will draw the water into the lumen, okay, and they will promote the peristalsis. Okay, they can the side effects include the bloating, okay, and sometimes the side effects can also include the diarrhea. And please remember, if you are having a diarrhea, okay, then you can have a metabolic acidosis. You will have a low potassium level, you will have a high chlorine level. Okay, very important.
Isn't it like in diarrhea we lose bicarbonate? So
Yeah, exactly. That's why the metabolic
that is why
acidosis.
we are.
Yeah, exactly. Because of the loss of bicarbonate, you will having a metabolic acidosis. Okay. Even if you are having a diarrhea, okay, then you can also give the patient bulk laxatives. Okay, because they will increase the kind of consistency of the stools, right? So you can use the bulk laxatives both in case of diarrhea as well as in case of constipation. Okay, in case of diarrhea, they will increase the consistency of the stools to decrease the diarrhea. In case of constipation, they will draw the water to promote the motility. Is that okay? Yeah.
Could you please repeat it once again?
You can use the bulk forming laxatives like the psyllium, okay, in case of both the diarrhea as well as the constipation. In case of constipation, they will draw the water, okay, and they will cause the peristalsis. In case of diarrhea, okay, when you give the patient fiber supplements, then it will increase the consistency of the stools, right?
Okay.
And if they increase the consistency of the stool, then it can decrease the diarrhea, right?
Okay.
That's why bulk forming laxatives both for the diarrhea as well as for the uh, constipation. Okay, very important to note. Okay, now comes the osmotic laxatives. Okay, and the osmotic laxatives, it includes the magnesium hydroxide, the polyethylene glycol, okay, the magnesium citrate, okay, and yeah, and the lactulose. Okay, now so see, you have this lactase enzyme, right? And the function of this enzyme is to break down the lactose into the components so that they can be absorbed. But if the lactase enzyme is inhibited, okay, then the lactose will be present in the lumen. It will draw the water. It will cause the diarrhea, right? Similar thing is done by these agents. They're osmotically active agents, okay, like the lactulose, glycol, citrate, and hydroxide. Okay, so they will promote the water into the lumen because of the osmotically active substances, and they can cause a diarrhea. Okay, so if the step one asks you the mechanism behind the osmotic laxatives, it is same as the patient is having a lactose intolerance. Okay, very important to note. It is same as the patient is having a lactose intolerance, because in case of lactose intolerance, it will be the osmotic diarrhea. Similarly, in case of osmotic laxatives, the patient will be having a osmotic diarrhea. Is that okay?
Okay.
Other thing, the lactulose, okay, it could be also useful for the hepatic encephalopathy. We have discussed that already, right? They can cause a diarrhea, they can cause a metabolic acidosis, low potassium, high chlorine, right? And they can also cause a dehydration. Sometimes these osmotic laxatives can also be used by the bulimics for the weight loss. Okay, very important to note. So yeah, any doubt on the osmotic laxatives?
I have one doubt.
Yeah.
So basically, osmotic laxative and bulk laxative both are acting by drawing water into the lumen, right?
Yes.
Okay, okay. So if there's a confusion between which one is acting similar to lactose intolerance, then the better answer would be still
Osmotic.
osmotic laxative.
Yeah, exactly. Osmotic one.
Okay, okay. Thank you.
Okay. Then comes the stimulants, which stimulate the receptors in the GI tract and cause the uh, diarrhea or the mobility increase. Right. They are the sena and the bisacodyl. Okay. I didn't mention about the bisacodyl, but the UVL does, and most of the questions of the stimulants are on this one, the bisacodyl. Okay, so you can mention that in the first aid. Sena and the bisacodyl. Okay, these are the two agents which will stimulate the enteric nerves. Okay, and they will cause the colonic contraction to promote the motility. They can cause a diarrhea again. Okay, and yeah, that's all. And mostly they have the effect on the colonic contraction. Okay, see the colon, not the small intestine. Okay, so although they have a small effect over the small intestine also. Okay, but the major effect of these stimulants is on the colon. They will cause the colonic contraction. Very important to note the location of the action of these drugs. It is the colon, not the small intestine. Okay, then comes the emollients or the surfactants. Okay, and the surfactant is the docusate. Okay, it again promote the incorporation of water and fat into the stool. Okay, because it will decrease the stool surface tension. Okay, the function of these agents is to decrease the stool surface tension to promote the incorporation of water and fat into the stool, right? So again, they can increase the mobility, they can cause the diarrhea as a side effect. Okay, other agents are the chlorine agonists. Okay, and the chlorine agonists, they actually causing the activation of the chlorine channels, right? And by activating the chlorine channels, they will cause the efflux of the chlorine in the lumen. And whenever the chlorine is in the lumen, it will draw the water along with that. Okay, and that's how they can cause the mobility and the diarrhea, right? And the drug include the lubiprostone. You might confuse this lubiprostone with the prostaglandin analogs because it has a prost in the name. Okay, so don't do that. Do not confuse the lubiprostone with the prostaglandin analogs, right? Lubiprostone is a calcium channel activator. Okay, so it will cause the efflux of the calcium into the GI lumen, and that can cause the diarrhea. Okay, then other agents are the mu receptor antagonists. Okay, because the mu receptors, they actually promote the constipation. So by inhibiting the mu receptors, I can cause the diarrhea, right? Like the methyl naltrexone, very important. This methyl naltrexone, it cannot cross the blood-brain barrier, so it has no effect on the CNS. It will remain in the GI lumen only, so it will cause the diarrhea there, right? So if the step one asks you specifically about the opioids, okay, what is the counter inhibitory substance for the effect of opioids? Okay, it would be the methyl naltrexone. Okay, very important. So yeah, any doubt over these laxatives?
Methyl naltrexone is full antagonist or partial antagonist?
It is full antagonist.
Okay, thanks.
Yeah, I think it is full now. Let me confirm it. But yeah, it's full, I think. Give me a second to confirm. Yeah, it is full antagonist. Naltrexone with naltrexone. The partial one is the buprenorphine. It is the only partial antagonist, okay, or agonist, you can say. Buprenorphine only, right?
Yeah, thank you so
Okay.
much.
The aprepitant, okay, which is a substance P antagonist. And please note the function of the substance P is to induce the pain, first thing, and to induce the vomiting. So by using this aprepitant, okay, I can inhibit the substance P, which will block the neurokinin 1. Okay, the substance P actually activate the neurokinin 1, which can cause the vomiting in the brain, right? So by inhibiting the substance P, I'm blocking the neurokinin 1, which inhibits the chemoreceptor zone in the brain. So by that, it will inhibit the vomiting. And I generally use this agent for the chemotherapy-induced nausea and vomiting. So two agents for the chemotherapy-induced nausea and vomiting. One is the ondansetron, and second is the aprepitant. Okay. And the other agents that I can use for the antiemetic therapy, this includes the histamine blockers and the muscarinic antagonist. And you use these agents only for the motion sickness. Okay, the receptors for these agents are present in your ear, in your brain directly also, right? It will sense the level of the fluid, okay, the endolymph, right? And that's how these receptors can promote the vomiting. Okay, so you give the patient anti-muscarinics or the antihistamines to promote to cause the to inhibit the motion sickness. Okay, and the drug include diphenhydramine, maclizine, promethazine. For the muscarinic antagonist, the main drug is the scopolamine. Okay, so anti-muscarinic, antihistamine for the motion sickness. Okay, and this anti-dopamine drugs like the metoclopramide for the
Diabetic
migraine,
gastroparesis.
yeah, for the nausea vomiting. Okay, it is for the migraine induced nausea vomiting, right? For the chemotherapy one, you will use the ondansetron and the aprepitant, which is a neurokinin 1 or the substance P inhibitor. Is that okay for the antiemetic therapy?
Could you please explain aprepitant once again?
See, aprepitant is an inhibitor of substance P. Okay, if you go forward for the neurology section, you will see that this substance P actually activate the neurokinin 1. And by activating the neurokinin 1, it will activate the chemoreceptor trigger zone in the brain, the CTZ. Okay, and by activating the chemoreceptor trigger zone, it will cause the vomiting. Okay.
Okay.
So I'm actually using this drug, the aprepitant, to inhibit the substance P so that the neurokinin 1 will be inhibited, and and now the CTZ zone will not be activated, right? And it will get the relief from the nausea and vomiting because of chemotherapy.
Okay. Okay. Yeah, I got it.
Okay.
Thank you. Yeah.
So the aprepitant and the ondansetron for the chemotherapy-induced nausea vomiting. For the post-operative nausea vomiting, you will use the ondansetron. Okay. For the migraine-induced nausea vomiting, you will use the metoclopramide. Okay. For the motion sickness, you will use the antihistamine or the antimuscarinics. Okay.
Okay.
Make sure you remember the uses of all of these in a very specific situations. They, Stephen will give you some history of the patient for like chemotherapy or for the motion sickness, and they will ask you what drugs you might give for the treatment, right? And why specifically I'm using the ondansetron for the chemotherapy-induced nausea vomiting?
It will not cause extrapyramidal symptoms.
Okay, but why they are so effective actually?
Because the chemotherapeutic agent directly stimulate the CTZ.
Not a major factor, minor one you can say. See, the chemotherapy always causes damage to those cells which are rapidly dividing, right? In the stomach, you also have the stem cells which are rapidly dividing all the time, right? And you also have the serotonin receptors in the stomach, right? So whenever you give the patient chemotherapy, it will cause a damage to these cells, and the receptors get activated. Okay, and the receptors will take the transmission to the CTZ center, right? And that can cause the vomiting, right? So if you inhibit the serotonins in the stomach, right? So the nerves, the impulses will be inhibited and the patient can get a relief from the nausea and vomiting. Right? It is because of damage which is caused by the chemotherapeutic agents to the stomach. Okay, or the intestine. Yeah.
Got the point.
Good. Okay. Any more doubt on this chapter? Someone missed today's class. Don't worry, you get the recording. I will upload the lecture today, don't worry, as soon as possible. Okay. Any more doubt?
No,
As soon
thank
as
you.
possible, I will upload the lecture today, okay? No doubt, I think.
No.
Okay, so we are
No.
done with the, yeah, so we are done with the GIT. Okay. And I think we should take, yeah.
No, I say thank you so much.
Okay. Okay, thank you so much. Okay, so we will take the today off after that. Okay, we are done with the GIT completely. From tomorrow, we will start the HEMONC, okay?
Okay.
Okay, does any one of you have the exam in this month or next month, or within 1 month?